Hey, antse re simolola tiro ya rona ka thapelo. Jaanong re kope ope yo ka ithaopang gore a rapelele. Any volunteer?
Father, in the name of Jesus Christ, we thank you, we bless you, we exalt you, King of glory, we revere you as our God. We know that you alone, Jesus Christ, you are the first and the last, the Alpha and the Omega. We put our entire trust in you. We know, King of glory, that we do not have any wisdom. There's absolutely nothing we can do without your help. That's why we ask and call on the Spirit of the living God, Holy Spirit, to join us and lead us. All of this we do, we ask, in the name of your Son, the Lion of the tribe of Judah, the Ancient of Days, Jesus Christ of Nazareth. Amen.
Amen. Mundo mabeo ke morapedi ba. O re rute thapelo. Hora gore re itsane mme nka supagela gore bangwe ba rona ba tla re joina re tsweletse ba na le mmiti yo mongwe gape o ba o tseneng ta re ntse re tsweletse ba tla re joina honorable Digwa, honorable ke kgonerile, honorable Motausane, at least 3 bona ke thomamisa gore ta re ntse re tsweletse ba tla re joina. Nna ke bidiwa Taolo Boipuso Lucas, ke mo palamente wa Bobirwa, ke modulasetilo wa Public Accounts Committee. Honorable members.
Inajame ke Victor Pololo, Kanye West MP. Thank you.
Ke bidwa Boniface Mabeo Gamalete. Ke bidwa Motlhale Mamwalu Sikonkanke.
Uncle Shima Munacheng, Mulepula South.
Thank you very much, honorable members. The 3 AGs.
Morning. Motlhabane Puso, Attorney General.
Dumelang, Bakang Motlhake, Office of Accountant General.
Mishozi Maziba, Office of the Accountant General.
Good morning, Janet Mahana, Office of the Auditor General.
Kibida Oscar Asa, Officer Auditor General.
Thank you very much. County Officer. Oh, okay.
Karen Matasa, Attorney General.
Thank you very much.
Amanda Molifi, Technical Advisor to the PAC.
Thank you. County Officer and team.
Good morning, Honorables. I'm the Permanent Secretary in the Ministry of Health.
Good morning.
Morning.
Kibidua Romansi Rumola from Office of Ministry of Health.
Thank you very much, Master Rumula. Karon was a short center. What ministry?
Accountant General.
Okay. I guess Rataiti Baba wants to go Jagger. Akere Pierce. Karataiti Baba wants to relate. Thank you. Raburian was an Rika, ne? We take oath. By Topel or Zaka by the Lepozaka affirmation. Havikana, Raukai Magadinao. County Officer. Mobile Bokala Haola Lamulema, Mobile Villing, Hilo Disabai Vili, Butcholeta Lamuja, Owen Salamra. I. Swear by Almighty God.
Swear by Almighty God.
That the evidence I shall give.
That the evidence I shall give.
Before this Committee of Parliament.
Before this Committee of Parliament.
Shall be the truth.
Shall be the truth.
the whole truth,
the whole truth,
and nothing else but the truth.
and nothing else but the truth.
So help me God.
So help me God.
Thank you, Pierce.
Yeah.
Thank you very much. Hela Jalo, Director of Finance. Tansala Morago. I
I, Roman Surumola,
swear by Almighty God
swear by Almighty God
that the evidence I shall give
that the evidence I shall give
before this Committee of Parliament
before this Committee of Parliament
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing else but the truth.
and nothing else but the truth.
So help me God.
So help me God.
Chief Accountant, my detail and Director, Finance Manager, Chief Accountant, after the oath, then I wish to welcome you, Minister of Finance, Mickey Super Wanegori. Honorable members, it's going to be yet another long day. I have been briefed by Accountant General and the technical advisors that they are in non-moving items. There are 490 impress non-moving. I've further been informed that there are 460 overpayments. I have also been informed that there are 286 retentions. That should give you an idea of the amount of work that awaits us in terms of the books. And so I say this and plead with honorable members to be very brief in their questioning, especially when we are at the level of the executive summary. And I also advise the chief executive officer, the accounting officer, to be very pointed in terms of the responses that she gives so that we can save a bit of time. It is by far the biggest ministry, I think, in terms of non-moving, in terms of interest, in terms of retentions. So I'm advised. So, make boile khaye ke tsela ke well ka ka re tsetsa ba bangwe re tawre simulla ka executive summary me executive summary ke yone hela e gompieno e re neelang a window into the past, current and the future, because the buka tsone re hantse re dira tsa 2022 ka jalo when we sound like we are talking about the present me re dira ka dibuka tsa 21-22 the executive summary so dictates that you give us a mandate and then you give us what is currently going on and what the plans are going into the future. So ne se pa italang ga ngwe re bua dikgang e tse tsa gompieno mme di buka ile tsa 21-22 ene ba ngwana le go tsietsega go batla re nna re ntse re tlhalosa kgaio e se lona ke ra ba ka re bile re rediwa ke ba bangwe to ba bua ka dibuka tsa 21-22 mme jaanong ba botsa dikgang tsa gompieno ke ka ha thulaganyo e ntseng ka teng ya PAC mme ka gore yalo PS re tla kopa gore re neele a presentation of your executive summary to be followed by an engagement with MPs.
I'm honored to present to this honorable committee the Memorandum of Progress on the report of the Public Accounts Committee of the 61st meeting 2021-2022 annual statements of accounts and the responses to the Auditor General's report on the accounts for the financial year that ended on the 31st of March 2022. The mandate of the Ministry of Health is really to coordinate, to lead the health sector by formulating policies, setting standards, implementing regulations, as well as ensuring that quality and affordable health services are available to all. The ministry exists to promote integrated, holistic, and sustainable, promotive, preventive, curative, and rehabilitative quality health services to the nation. The strategic priorities of the ministry are, one, to revitalize the primary health care. And the significance of revitalizing the primary health care is that nations that have prioritized primary health care are able to provide a much more universally available health system that doesn't impoverish its people. And also it allows for strong community ownership. The second one is to optimize our specialized health services. Now, a properly functioning primary health care should be able to deal with almost 80% of health concerns of the community at the most efficient cost. However, specialized health services, even if they were to cater for 20%, they usually would cost almost 80% of the budget. And so it's therefore important as a ministry that we optimize in the way that we're providing specialized health services. So for both of them, that also means that we're going to have to define the packages of care that people should expect to find in each of our health facilities. The third priority is to re-engineer our operations. As we will see when we go through the books, the majority of the challenges and the majority of the things that have not been done are because of the inefficiencies in our processes. And so that is why optimizing or re-engineering processes is one of our key strategic areas as a ministry. And then our fourth one is to strengthen oversight and regulations to ensure that there exists a supportive legal and policy framework for the health system. And these priorities are actually anchored on the National Health Policy that's still under review and the World Health Organization's 6 Health Systems Building Block. Recently, the government has promoted and spoken highly of the need to provide universal health coverage. Currently, Botswana stands at 54% of universal health coverage, which means the ability for one to access cost-effective health care of a certain quality when they need them and where they need them without suffering financial risks, without suffering financially. So as we know, Botswana has an expansive health system which has mostly received one of the highest provisions of funding from government. The provisions, however, haven't always equated or haven't always been commensurate with the improvements in health outcomes. And Botswana still finds itself with high rates of maternal mortalities and under 5 mortalities, as well as malnutrition. So for us to realize universal health coverage, therefore, we need to refocus on health promotion, disease prevention, comprehensive screening for disease and early treatment, surveillance at community level. Government has also decided to introduce national health insurance. Now, national health insurance would be a vehicle for realizing universal health coverage. National health insurance would define for us where the funds would come from to fund a health system that is universally available and that assures Botswana a certain quality of health care. And so it will talk to the purchase and also to the provision of the health services. And this, therefore, is going to require and calls for a major reform in the way the health is going to be funded, as well as the way that is going to be provided. And the other issue that we'll talk to is Sekitumila Masire Teaching Hospital, which actually was constructed, and the construction of which I think ended in 2014. But it hasn't really given Botswana what it was intended for, because as a teaching hospital, the vision of the country was that it will become the quaternary healthcare center for the nation, the highest referral hospital, but it will also be a center of excellence for training of healthcare workers and also for research. It is the reason that the Honorable Minister of Health, Dr. Stephen Modise, convened a task force that evaluated and looked into the models, the best models of making Sekitumila Masire open to the public and also delivering on its 3 mandate of clinical care, training and research. So that's something that actually has been, the proposals have been approved recently by Cabinet to open it up to the public. Now, the other big issue in the reform is the relocation of primary health services to local government, which will really allow the services to be responsive to the unique needs of populations and communities, and therefore provide a more relevant person-centered care. Although the responsibility and the policies and the guidelines and the overall oversight would still remain with the Ministry of Health. And the Ministry of Health will also still remain with the hospitals. So I will quickly go through give health updates. The country was honored in 2023 to be recognized as having surpassed UNAIDS 95 goal or path towards elimination of HIV and AIDS. And recently, most recently in May, Botswana was also recognized as the first country in the world to attain UNAIDS gold tier status, which is on the path to the elimination of mother-to-child transmission of HIV and AIDS. I must hasten to say, though, that these laudable achievements are seriously threatened at the moment by our current economic stage, because to be able to sustain that, we need to continually continue surveillance, to continually know if our pregnant women do not have HIV, in order to be able to protect their unborn baby. And we need to know also when the newborn are born, when the children are born, whether they do or do not have HIV. And currently we are not in a position to do that because unavailability or a challenged diagnostic capacity, where we do not have reagents because of financial constraints. Recently, the country has also been hit by diarrheal outbreaks. Diarrheas are usually expected and they are seasonal. But normally, children should not die from diarrheal diseases. And this year, unfortunately, we had 31 deaths from diarrheal diseases. And then the cases have started going down. And one of the biggest challenges that we found that led to or that leads to death in children is usually children who are under a year old and children who are malnourished, particularly those who suffer acute malnutrition. And we also noted that suboptimal management was also contributes. And so the ministry has actually undertaken to provide retraining and supporting for particularly severely affected districts. And Botswana also recently had a malaria outbreak. This is in the wake of the aim to eliminate malaria. Botswana is one of the 8 countries in sub-Saharan Africa that had been earmarked for elimination of malaria by 2030. The recent rains, however, led to a significant outbreak of malaria, with up to more than 2,000 cases and 8 deaths. We are still confident, however, that with adequate interventions, we can cover lost ground. And recently, the country, the president of this country assumed the leadership of the African Leaders Malaria Alliance, which is also helping Botswana to see how we can continue or we can get back on our path to elimination of malaria. And then TB and HIV are another, some of the other challenges that we're grappling with, but I've already talked to HIV and AIDS. And TB also, recently, it has been on social media and a number of our media that we had run out of TB medications. And as I have said, many of these gains that the country has had for quite a while are significantly and seriously being challenged by our financial situation. Sometimes it's not even because we don't have the budget, but because of challenges in paying those who actually are providing the services. That leads to them not being able to supply the goods and the commodities that we need for the health system. So, but we are still confident that we have found a way to have reliable supply of TB medication. Currently, we do have the treatments for both TB and HIV/AIDS. I just thought it's important to assure the nation. We are challenged currently with malnutrition, and the just ended drought has not helped the situation. Normally the country aims to about 3%, but currently the national average of malnutrition stands at 4.4%. And there are areas that are particularly hard hit by malnutrition. So another area that I've just kind of hinted is the availability of medicines. Generally, we aim to have all our medicines at 90% availability. But this has been significantly challenged in recent years. The COVID-19 pandemic had significantly affected availability of medicines globally. But by 2023, we have started to recover, in that our availability had even surpassed 80%. But we're starting to see that the availability of medicines are starting to plummet significantly. And that is primarily because we have not been able to pay the people who supply us with medicines because of the economic challenges. So that even when we do have a budget, and because most of our medicines are bought or are sold in hard currency, then it has been challenging to actually pay for these medicines. But so far, we had always wanted to at least have a 6-month supply in the country. But at the moment, a number of our medicines, even those that we say are at 70%, we are talking about 3-month supply instead of the 6-month supply. That gives us enough buffer to do the procurements. The ministry, however, has tried to stabilize the provisions of medicines by giving framework contracts, so that there are people who we already have contracts with that are supplying medicines. And though this should really work well, it's currently just challenged by the fact that some of these are owed significant amount of money. The other issue that I will talk to is the infrastructure. The ministry, we have 3 referral hospitals. If we add Sekitumila Masire, which is going to be one of the as it opens to the public, would be 4, 9 district hospitals and 17 primary hospitals. And then we'll talk about the headquarters, National Health Lab, Central Medical Stores, and the former TB ward. Now, most of our infrastructure are not in very good state of repair, and this has caused stoppages of services on and off. And both the infrastructure and the availability of equipment, the right equipment, and shortages of the requisite personnel has significantly challenged our ability to provide the quality of health that we have and we should promise Botswana. In fact, I said one of our strategic goals, one of our strategic, our strategy is to optimize specialized healthcare. And part of optimizing is to ensure that when our theaters are working, to be able to deal with the backlogs. But we are currently challenged primarily because we do not have adequate financial provision to actually do the renovations. But also we are also aware that when in the past there had been some provisions, we're not always efficient in the use, in making sure that the renovations are done timely and at the right cost. So those are issues that part of re-engineering our processes is actually to see how we are going to address those challenges. We have, as a ministry now, actually set up minimum operational, so to ensure that there's minimum operation state of our theaters. We have developed a maintenance plan. We also realized, this is part of our re-engineering, that the ministry, by and large, did not have, hadn't developed the maintenance plans so that we didn't only have reactive maintenance, but the ministry has now developed the maintenance plans that obviously currently is just challenged by the resources, but we have plans to how best to ensure that our facilities are functioning optimally at all costs. And our hope and prayer is that this economic challenge will pass so that we can actually offer Botswana the health that they should receive, or the health care that they should receive. Now, talking to the development budget of 2021-2022, the ministry had a development budget of 257,977,906 pula and 87 tabe. 87 tabe. And this was mainly for the infrastructural project of construction of the Moshopa Hospital and then improvements of the Shakawe Hospital, as well as procurement of staff houses through the Public Officers Housing Initiative. As of March 2022, March 31st, the ministry had spent 97.8% of that approved budget. The recurrent budget, the budget of 21-22, the recurrent budget was 7,895,464 pula. I apologize. It was 7,895,464,140 pula. And then there was an increase that year for the warranted provision, and so the total or the final warrant was 9,581,859,239 pula. The ministry had an over expenditure of 108,000 pula, 108,699 pula and 76 tabe. So the recurrent revenue, the ministry collected 53,405 pula against an estimate of 16,737,900 pula. And the 80% of that total revenue was actually from the COVID-19 PCR testing. In conclusion, my ministry is committed to the provision of quality healthcare services, and we are quite aware that as a ministry we have not been efficient, and there have been figures that we've been given that we actually are operating well below where we should be expected when in terms to the efficiencies of utilizing the resources that we are given. And so we are quite committed to ensuring that Botswana will get quality healthcare services that is sustainable, which means that we would use the resources that we are given for what they are given for in the most economic way possible. And we are working very hard to ensure that this happens. And we are also committed to ensuring that Botswana, every Botswana, irrespective of where they are in the nation and their economic status, will receive a certain quality of health services, ensuring universal health coverage. I'm also grateful to the team that has worked really hard to consolidate and prepare these reports under very strict timelines. And I also appreciate the PAC Secretariat, the Office of the Attorney General, Office of the Accountant General, and Office of the Auditor General for the support that they gave in the preparation of this report. Thank you very much.
Thank you, Piers. It's time to engage. Honorable Monageng.
Thank you, Mr. Chairman. Rally Woha, Accounting Officer. You have worked on this report against tight timelines. Next time, let's have a idea. Na kwa sampele teng go le dire le na le nako the report ya itlhalosa sentle jaaka le bua gore you are committed to ensuring quality and cost effective health care to Botswana. Ke maikaelelo ke keletso ke maikemisetso a lona mme re bona di patela ma dilemo seemong se sa siamang thata all over the country, and health care is at risk. We have a state-of-the-art hospital there, Scottish Livingston Hospital. Seemo sa sone se a hakamatsa thata. We once visited it recently, the Minister of Health, Jakano Ubwa Kaina Kantil. Merited se lo gore tota hela seemo ke se sengwe mo lampelo. Santlha ke di building ka dintseng ka teng. Sa bobedi, and I think what I'm saying largely applies to many other hospitals. We tell our occupancy rate is very, very low, 40%. And Nerebutsa superintendent gore hospitala sentse ana occupancy rate is about 40%. Hanne gongwe le a hotel, I'm born your private hospital, I be about 40% occupancy, and then the rest of the wards didn't say hela di jahela. Tota a business in eka survive, and obviously the answer is no, you wouldn't. And the reason why hotwe gagona batho ba ba le mo di wading tseo balwetsi is not gore molepolole le surrounding villages gagona balwetsi. Issue ke gore gato gagona equipment dingaka di a tlhaela, and therefore batho ba referiwa to bo gaborone. So ke seemo se le gore le se lebe thata.
I think let's go to an engagement, clarification. The
question is, what do you intend doing? Thank you, Chairman.
Thank you. Okay. Thank you, Honorable Monageng. It is true, as I've already admitted, that our infrastructure is not in the state it should be to be able to provide the care that actually Botswana need. And one of the biggest challenge is that there seem to have not been preventive maintenance that was budgeted for. So there was never budgetary provisions that were adequate to actually continually provide preventive maintenance, which led to most of the maintenance being reactive maintenance. As I've said, we have now developed a preventive maintenance plan, but now what it will require is resourcing to ensure that there will be the funds to actually follow through with the plan. The second one is that we as a ministry, our plans, and we have planned to ensure that our district hospitals will also have specialists. Not all the specialists, but the basic pediatrician, physician, surgeon, obstetrics, and gynecologist. And Scottish is one of those hospitals that those provisions were at some point provided, but people move sometimes. Scottish also has another challenge, and one of the biggest challenges is water. And water makes it very difficult. That sometimes even when there were surgeries that were planned, they have to be cancelled because or they started very late or they are because of water. So Mulepolole has a serious water issue. But having said that, one of the things that we are working with the University of Botswana on is to decentralize training. And Scottish is one of the facilities that we actually earmarking for decentralized training. And for all the health cadres, and which would mean that actually would have more doctors and more other trainers, whether it's the nurses who are specialized to provide the training. And the plans are in place, and now we're going to look at how do we actually resource those plans to make sure that they happen. But and we know that before coming to the ministry, I was working at UB, and Scottish is one of the places that we had always wanted to train our students. One of the biggest challenges was always water, that we were not able to actually, sometimes we even had to take them there every day. So I think, one, we need to attend to the bigger infrastructure and support systems. And then the other one is we have plans and we're praying and hoping there will be the resources for us to be able to implement the plans.
Thank you, Ma. I think we really appreciate the location of primary health services back to local government. Mediclinic, I don't have to elaborate as chairman but my suggestion and question is, this issue or adopt something encouraging the public sector and probably corporate and probably individuals by by mesent ya ka re tote bo muti ba kokota kwano yana gore gonde le gore le encourage gore adopt a clinic gore gongwe dio tsa rona di tedisimon le go nna botoka in terms of go improve dikago bogolo jang le of course services.
Honorable Monageng, that's a great suggestion. We hadn't worked and we hadn't worked around that. But I think that with the clinics now much more at a local level, that those may actually be much more possible for communities to engage with the systems that they already are there in each of the communities for the adoption of clinics. And I know that, for instance, Maunatala Clinic had worked, the community had actually worked with other private investors to see how they could build part of or develop some of the wings of that. So it is possible, but it hadn't been a plan that we ourselves had developed. I know also that, for instance, in June 2024, on the 24th of June, we will be launching the first pediatric or kids-friendly operating theatre in Princess Marina, and maybe the first of a few in the country. And this is also working with people who we've partnered with, and they had the resources to support it. So yes, it's a great idea. We hadn't taken it as a strategy, but it does work.
Thank you. There's an outcry. There's an outcry, yeah, shortage of essential medicines and medical supplies. That's lot. And I don't think something has to be done. What do you intend doing in the immediate future?
Thank you, Monaching. I did talk to that as part of the summary. As a ministry, our plan is to, when we say there are no medicines, that we should at least have 6 months supply. Currently, we are challenged and we are only able to have 3 months supply. Now, the medicines are divided into a number of categories. There are those that are called vital, and the vital ones are the ones that, you know, the high blood pressures, the ones that we know that are our life-saving medicines. And those we, in fact, try very hard to ensure that their availability is much higher, maybe than others. And so we, as I said, we ensured that we develop framework contracts. Because framework contracts, the intention is that they provide stability of availability, so that if you need something, you order what you need from the supplier, and because that you already have a contract, you've agreed on the amounts of the drugs. So we do have framework contracts with a number of suppliers. Currently, our biggest challenge is that we are struggling to pay them now. And we are struggling to pay them, not always because there are no funds in our accounts, but many times is because I'm sure the PS of Finance has already explained that there is no cash to pay them, because we would process all the things that are required to pay, but then the suppliers still come back to say they are not paid. If they have not been paid, they are not keen to bring the next batch of our order when they have not been paid for the orders or not completely paid for the orders. We're working very closely with our suppliers. We develop relationships, but because they are running businesses, also it's a challenge. And one of the other challenges is, even when we do pay, but we pay late, they are not able to pay their suppliers. And so when they try and get the medicines, then the suppliers have not manufactured the medicines for us. But as I say, we are working very closely with our suppliers to see how we can manage that and on a day-to-day basis, because currently this is really the most that we can do. Sometimes we also are using we're trying to use suppliers that are not the normal ones that you use. For instance, UNICEF. When we're really struggling, we've reached out to UNICEF to see how they could help us. And so we are waiting for them to assist us with some of the commodities that we're really struggling to have.
A very quick one as a bonus.
Let me just...
Very quick one.
How much do you owe suppliers? You have a figure?
I did not bring the figures. We do, like monthly, we look at those figures, but I did not bring them. But it's figures that can be provided.
It is?
There are figures that can be provided, but I did not bring them today.
Can we have them during the course of the day?
Yes, we can have them.
I think we should have them. I mean, it looks like it's a big thing. Eh? It's a big issue. Being unable to pay suppliers, yeah.
The last one, Chairman.
Gongwe se total sum gongwe e breakile ka tsela ka e breaka ka yone mme e se tona.
The suggestion is that you want to break it down if you can, but how say break it down to the last detail, but it must be broken down. Is that something you can do?
We could do that.
We could do it before the end of the day, and then we will keep on inquiring. The last one?
The last one, Chairman. The UDC-led government is encouraging triple P, and not all over the country, in some places, we do have the Institute of Health like IHS, Komulepole, and other places. I'll always make reference to Molepole because I haven't visited others, but I'm not, you know, so ke bua hela ka Molepole, ke bua ka
You
lehatshe
see,
lotlhe.
I always caution that in
Yes.
PAC, really, we should be focusing on the broader picture rather than the local picture.
That's what I said,
So,
Chairman. I'm talking of the Institute of BOTSWANA botlhe, but I'll make reference to Molepole because I visited it. And I believe what I'm talking about.
But you get my point, right?
I get it, and I'll refrain from getting there.
All right.
The Institute, they are underutilized. Well, we tell state-of-the-art kitchen, catering facility, whatever. Ibile tswetswe go twe kana stofo ga se bereke. How would say for how long? 1.5 years, 2 years, which might mean cancers are outsourcing or whatever. But the bigger picture that I'm getting to is possible triple P. I have the opportunity to have visited Tekanelo College. Kitla ele gore e ka re ke hotel hela tota. Yaanong ga le ke la encourage triple T, you know, collaboration, partnership, le tsone dikwele tsa mohuta o. I did talk to management, ka one ke ba address ba invite. They are more than ready. And I'm saying the ministry of Ngwahane, they can encourage whereby that collaboration does take place. How the lecturers the private sector like Bitekanelo go and lecture there. They are ready, I'm telling you. And I get our the syllabus, you know, collaboration and all that. They are ready. And you can imagine my last sentence. You can imagine how me banabaluko IHS timo ka go linteng hela e be le gore ba bona go di professor di tla go ba ruta ka gore kwa go na le up to level of professor. That collaboration, that partnership, thank you very much.
Thank you, Honorable Monageng.
Thank you.
Yes.
Thank you, Honorable Monageng. I must just say, however, that IHSs are under the Ministry of Higher Education, being teaching institutions. So I would not be able to talk to them. I think what I could say is that our facilities, where there's opportunity, there's also opportunity for triple P, but I can't talk to training. I know, for instance, that the old Mahalape Hospital currently hosts a private physician who does dialysis. And also in Maung, at the Solatebe Hospital, also a wing has been outsourced or given to a private entity to provide dialysis services. So yes, those things are things that need to be looked at in a very strategic way so that there's a proper win-win situation. Thank you.
Thank you very much, Honorable Pologolo.
Ke a leboga Modulasetilo, dumela accounting officer. Ma ha ke manolla hela mo tekodisong ya gago. O supa ha ele maikemisetso le maikaelelo gore o le hitlhelele botsogo jwa botlhe. Mme gape o bo supa gore puso e tsere tshwetso ya gore e tlise National Health Insurance. O bo tswella o supa gore mme sone se gore se kgonagale go tlhokana le major reforms mo tirisong ya tsa madi segolobogolo. Ne ke re gongwe o re sedimosetse gore these major reforms o bua ka eng segolobogolo ka gore yone National Health Insurance ke phologolo e leng gore ga re itse mo setšhabeng re le bantsi. So go ka nna mosola gore batho ba sedimosetswe gore thulaganyo e ke e tlang ka motheloheng.
Yes.
Ke a leboga, Honorable Pologolo. National Health Insurance is implemented differently mo mahatsing a harologaneng. ha o ya ko UK kana o ya ko Zambia kana o ya ko Kenya o tla itlhela gore di implementiwa differently. Because of that, for us to know what will be the best model, national health insurance for Botswana, we're actually going to embark on stakeholder engagement. That was launched a couple of weeks ago. Janu, we are still putting up a team that is actually going to talk to different groups of people and communities to find from Botswana what their understanding is, and more importantly, what do they actually want, so that eventually what is developed is something that will work for Botswana. So I have ideas of things that can be done, but that may not necessarily be what eventually would be the best thing for Botswana. But in a nutshell, national health insurance basically means that you have decided where you're going to mobilize resources to ensure that we don't get to a situation like this, that when the rest of, where we can't even buy medicines. That is, so where can you get money that you can sustainably be able to get or to have free sources? And then also, how are you going to buy services? Are we going to only use public facilities, or are we also going to use private facilities? If we're going to use private facilities, how much are you going to be willing to pay for the services that you're going to receive? So these are all the things that actually is going to need a lot of work. That's why I say it's a major reform that is going to need a lot of work for us to eventually get to a point when we know what will work for Botswana, and also test it in a few years. Because I know Kenya started on one model, it didn't work out. They have completely refurbished, and they're now implementing a different model. So that is why I'm saying we don't have a model yet, but we are working on what will work for Botswana.
Ka ha buang ka teng a ra gore ngaka ya setso kwa ga sekitla mokhanselara ko lorolwane a sologele gore e tla nna motsayakarolo mo goreng le ene a nne le seabe gore tshwetso ga ditsewa a ba kile a ntsha lentswe la gagwe le ene.
Maikaelelo ke gore re be re heditse di-stakeholder engagement sometimes ngwaga ono gore be eventually parliament e lebelele policy eo. Jaanong go ka nna ga se ka ga kgonagala gore Motswana mongwe le mo rotlhe ya ka re le 2 whatever million I have a say. But the hope is that there will be enough representation of the voices that will be heard, even though it may not be every single one of us, to be practical, and also because it costs actually to go around.
Okay, being practical, like you put it, who are these stakeholders you're looking at? Your parliamentarians, your councillors, your traditional doctors, part of these dikhosi, are they part of the stakeholders?
Yes, sir, I assure you that they will be part of the stakeholders.
With the primary health care, the national health...
in terms of the... Right now you're still at the consultation stage, right? Consulting the stakeholders. In terms of your projections, when are we likely to see a finished product and maybe the operationalization?
Our hope is that things just never go as quickly as you want. Our hope would have been that by the time we got to the June Parliament, we would have had a policy. But there's been so much delay in starting the stakeholder engagement that we're hoping that maybe by the end of the year, we would have something. But that is because first you have to have a law that makes sure that you can implement. So first and foremost, what stakeholder engagement are actually to help us to define and eventually come up with a policy and a law of national health insurance that Botswana can implement. So just getting that done may be, we hope this year, to have the law that would allow it to happen.
Yes. Consultation, and then the policy, and then the law, and then implementation. Are you being realistic here?
In terms of implementation, I am very careful because I know that the president of this nation has made pronouncements, and I cannot say pronouncement that seems to be contrary. So, but what I'm saying is, at the moment, we are actually looking at what is it that Botswana wants or Botswana wants. And that will lead us to developing a policy that would have to go even up to Parliament. And hopefully the policy would be such that it can be turned into a bill of national health insurance bill. And our hope is that this could be done this year. And then once it's passed and Parliament has passed it, that is when, because part of passing it also is to agree where the funds would be, where the revenue would come from. And so our hope is that this can be done this year, and then next year would be looking at how to implement it, having looked for the resources that will be required.
P.S., you are the expert. You are the expert here. You say you don't want to contradict the president. I don't think you should go there. What you need to do is just to give us an expert view on what you think could be the implementation schedule for this. And you also want to say something very realistic so that we don't come back to you to say, look at what you told us a few months ago now. We are headed nowhere. So I'm just trying to say to you, in as much as you don't want to contradict the president, but you want to be realistic, because what you are talking about right now, about consultation, about policy, about the law, about implementation, and then you are saying end of this year.
The policy and hopefully the law. That's my hope. Okay. But implementation will actually come out of those, because those would provide the framework for implementation. And so the most realistic thing is that the implementation would probably be the next financial year, because we would still have to look for resources.
Okay, that's what you say. I tried to, probe and ask, but you are still saying end of the year, policy and law, implementation next financial year.
That's what we're aiming for.
Chair, if one may ask, I still don't think an ordinary citizen out there understands and has a view what is national health insurance. Gompieno ba ya dipateleng hela go batwa ma 2 pula ma 5 pula go na le ba ba yang dipateleng ba tshwerebo di medical aid karata ba duela kgwedi le kgwedi. Can you paint a picture in a general form? Or of course, yes, there are so many systems that NHI, but the basics of it in terms of what? Amotswana tabaya no a duela 50 pula kgwedi le kgwedi. Amotswana tabaya duela la ke government 50 pula kgwedi le kgwedi. Aya private hospital e kana jang. Can you paint a picture for Motswana le kwa utora gatwe go tae?
Yeah, I think you made your point, sir.
Yeah. The truth of the matter is, as a country, unlike many other countries, as I talked to Kenya and Zambia, Botswana generally have had an insurance to provide to access health, because we were not expected to pay, except for 5 pula, which many times people don't pay. So Botswana generally, even though there was no name national health insurance, Botswana have always been insured by government to receive services, from birth to the very end. Even receive some most complex cases, because for the longest, if something can no longer be provided in the public health system, government has paid for people to access that care elsewhere. That is an insurance of sorts, because Botswana didn't have to worry about whether I can afford healthcare. Now, what this is likely to do then is to say, one, it would allow us to be able to because currently to decide whether somebody is going to go to a private hospital, a doctor makes a decision and then refers. And there are no tariffs that have been agreed. Whatever is going to be charged is what is going to be paid. But what the national health insurance adds into what already Botswana are enjoying compared to other countries is that now we need a way of a sustainable fund that will be managed with a fund order there that Botswana may not need to worry. But now we would ensure that there is an understanding of how much things actually cost and where those things should be. For instance, I'm giving us an example. We may, the national health, it may well be decided that for all, I'll just give an example because it happens, circumcisions, because we do circumcisions as part of prevention of HIV/AIDS. All circumcisions will be done at this level because we also need to define packages of care. And this is the amount that will be paid. This is the maximum that can be paid. And no one should have to pay extra. Because sometimes we can say, if you have a medical aid, maybe you can say, okay, medical aid can say this thing actually costs 100 pula. But as a doctor, Dr. Nkomazana can decide, for me, this is 150 pula. Therefore, if medical aid is paying 100 pula, you're going to give me 50 pula. But part of the national health insurance, because the idea is that nobody should be impoverished by healthcare, by seeking healthcare, is to find a way that we really look at what does it actually cost to provide services. And then if it's set, and nobody has to go and pay extra.
Let's give you the opportunity to consult. Maybe it will be much more clearer once you have consulted.
Maybe I
yes. Uncle Shima, give me a moment. Usupile stakeholder engagement is ongoing, and kisupa gore ke soloela gore e tla mphitlhela ko lorolwane, e tla itlhela Lucas ko kgaolong tse dingwe tsa ko Ntswele Moriti. But what I need to find out from you ke gore, whilst stakeholder engagement is ongoing, is there any constructive dialogue and joint planning to come up with this huge and very welcomed initiative by government?
Okay. I must say that we have been working with the support of World Bank and working also with others that will be affected to really rethink around what would national health insurance look like for Botswana. But as I've said, we have draft zero, but that draft zero is going to need to be informed by Botswana.
Are you already talking to doctors' union, those kind of people? I think that's what.
I think because some of those people were part of the stakeholders, they were part of the teams that were developed, that were working with the World Bank. But we haven't yet, we launched the stakeholder engagement, but we haven't yet gone out. And I'd said that it's because it took a while to put up the team. But our hope was that we would start in May. So the actual talking to people is going to start in June.
So there's not been any dialogue between yourselves, Minister of Local Government, perhaps Finance, just to mention a few that come to mind. I guess these are amongst the many maybe that you need to engage with in the formative stages while stakeholder engagement is ongoing.
I think though I will need to actually get somebody to brief me who was part of the team, because now I don't remember. I know that it was a multi-stakeholder, it was a multidisciplinary team that was working with World Bank. So I think they were represented, but I will need to check who were actually in that developed draft zero.
I choose to move on, but I would ask in passing or Botswana Kwagasita solo helaying with the NHI. Look, from your report, especially when it comes to medicine and its availability or lack thereof, usupile gore laboratory products, I believe you're talking of equipment and reagents, or they're in short supply. Would you not think gore gongwe there is monopoly here. But we see the same companies, they supply and closing new startups to also get their stake in the value chain. What is your take on that? Do you have the same companies that were and still are and monopolize the industry?
I'm not sure I have a very clear answer to that. I would need to see who's currently supplying and providing our equipment. I know that as a ministry, what we were and what we are and hoping to do. Okay, maybe first to say, our current situation now is not that the people who have who won the tenders are failing to supply. Is because that we have not been able to pay them, and therefore they are not able to keep supplying. So that is why we currently have a shortage. But in terms of whether we are using the same company, that one I would need to find out. But I think it must be said that we know that all the equipment and even the reagents come from outside the country. They're all imported. Now, what has happened over many years, I think some of the owners of the equipment and the reagents have partnered with companies in the country, and therefore, when you seek to procure, they would often only want to work with those that they had already been working with over time. But as a ministry, we're actually looking at a placement model as a way of dealing with shortages of reagents. And a placement model is, most companies actually make money out of reagents, not so much out of equipment. So that if we say, okay, we look what is the best equipment that the ministry wants to use, or whether for its efficiency or the cost or whatever, then the owner of the equipment places it. But all we buy from them is the reagents that, or the tests. So that's another model that we are looking at right now.
You just confirmed the fear that people have, or there's monopoly.
I think so.
Because companies hold agency and they introduce equipment that only them hold the license to sell the reagents, and therefore closing out any startup to have entry into the market. So you need to do something about that, for there to be fairness and others to also enter and do business with government. Still on the same monopoly, I mean, that goes even for pharmaceuticals. I would know of one or two companies that I've seen. By the way, I've worked in a medical laboratory lab when I was still young. So I know what I'm talking about. Companies that I was introduced to using their equipment, I still see that equipment in use today. So that is a monopoly, and something needs to change. Moving forward, there's a warehouse somewhere in Old Naledi. It has been there for the longest time. And there's some obsolete equipment. What is the status with it? Do we need to continue storing that equipment, reagents that have expired? Can you give us an update on the status concerning that warehouse?
I think with this one, I'm going to need to ask for specific information from the people that are concerned, if you allow me, because I think I would not be able to give accurate answer.
Where are the people? Are they here? We can allow you a brief conference. 1 minute, we can brief. No, you don't have to go anywhere for now. Okay.
going to find out.
He's going to find out. Oh, okay. There we are. Now, the second issue, we are parking. And you remember the first one?
Can you find out on the details from, SLA, Erin Dualing, it's been how long? And who do you all guy? I'm not ashamed to ask for rentals because we are here to interrogate use of public funds.
Yeah.
So it's important for the public to know what the Madiabona is and how much.
It's a fair question, don't worry about that. I agree, Lutulor Parliament are liberty information. The officer who is being sent to find information. Who to Lord what do I lay? Are you sure? Is that all you wanted?
The terms and conditions and the equipment. What is the intention to do with the equipment in that state?
You will give us the information after the break together with whatever else we have asked for. Go ahead.
Perhaps my third question is to do with private laboratories.
Private?
Yes. Okay. Back in the day, IHS used to train laboratory personnel up to diploma level, and these will be placed in medical facilities, government facilities, to head these laboratories. And apparently now they cannot be licensed to run private medical laboratories, and yet they take charge of laboratories in district hospitals and other government facilities. What is the rationale behind that, and why do we see private laboratories dominated by foreigners, especially those from neighboring Zimbabwe?
Very much, Piers.
Okay. Thank you very much, Honorable Polokolo. This one also I would need to find out. I'm not aware. I was not aware that because the licensing office is actually it's a part of the BHPC, Botswana Health Professions Council. Ideally, these should be semi-independent of the ministry. So I will need to find out from them who is actually licensed and what are the rules around it. So that one I will also find out.
Does that also go to the extent where you are not aware that many private laboratories are owned by foreigners?
That one I'm aware.
Why is that the case? Perhaps one needs to put it to you that this could be signs of corruption even. What is your take on that?
I do not know.
You do not know why foreigners dominate the private laboratories in terms of operation?
I do not know because, as I said, I'm going to find out what are the rules, what are the regulations, who can run a private laboratory. If maybe Botswana are being left out because there are laboratory technicians, that would be one thing, but I don't know whether that's the case.
He was saying diploma holders are not allowed to run private laboratories.
Yeah.
Could that also be a part of the reason?
It could, but there are Botswana who are laboratory scientists, who are degree holders. So so I can't say for sure unless I find out. That's the only reason.
Piers, please also look into how many laboratories government-owned are run by laboratory technicians holding a diploma. And to me, that should be the basis of why they are in a position to run their own private practices and make sure we localize some of these to create wealth for people within this. Lastly, the NHI. What are you going to do to cap a situation where we are going to create, I don't know what to call them, maybe medicopreneurs? Because medicine nowadays seems to be a big business. Are we likely to see medicine taking the form where business to another level?
Our hope is that NHI, if it's done properly, should actually cap that. Because NHI, for it to function well, must be supported by a properly functioning digital system that will be able to tell us, to track a patient from the community all the way to the referral hospital and to know what was done, whether that is something that NHI would pay for. Because the idea and the hope is that nobody would have to pay extra to what is already being paid by NHI. And therefore, our hope is that because we'd have sight of what is being done, currently we don't really have sight of what happens to patients generally. And so we don't know whether what is being done is what should be done, because it's a private thing that the patient pays and it ends there. So our hope is that they should cap it.
That would be our last answer.
No, I'm actually making a quick follow-up on the information she's to provide. On this one, diploma holders and licensing. Yeah.
Okay. All right. When PS, is that information that you can source during the course of the day, so that we add now another?
I know that the Director of Health Services is actually standing in for me at another meeting, but I can get someone to text her and find out who in their office would be able to give me the information.
You have the last one. No, that was the last one. So please, I think it will be helpful if we get this information today. I think it will be very, very helpful, because if you need to make a few follow-ups, then we can make those follow-ups. Honorable Mwalusi.
Thank you, Chair. Dumelang.
Thanks.
Chair, when you go to a funeral in Botswana and you listen to the caregivers give you a story of how the person passed, most of the time you get to sense the neglect and the collapse of the health system. So I normally ask them, baruti gore ba ska ba thola ba re modimo neile modimo o tsere ba bua nnetela gore modimo neile gormente o tsere. So that is what we say in Ngange, modimo neile gormente o tsere. This is because most deaths in Botswana can be avoided. They could be avoided if we had relevant medications. We have the staff. There's a story right now that is developing of an old man who is 104 years. Who gets a specialist in November. And in November, that old man won't be here. So, yeah.
Please.
That is the story of Botswana, where you see a specialist 24 months, 12 months after you are diagnosed. I have this issue, PS. Yeah, students who graduate from UB with qualification pharmacy. Right now in all clinics, we don't have pharmacy technicians. You had them for a short 1-year contract when the nurses were on strike. When the nurses came back, you didn't renew the contracts. Yeah, these students by UB, bare, banale, gore ba register,
But there's a mandatory internship that they need to do. They have come to the ministry to say, internship, register you. They failed. They've even said, we will do it for free. Because all we need is the experience so that we can be licensed. And look, you don't have pharmacy technicians, but you are refusing to give these people free free work for free so that they can get the necessary experience that they need to be registered so that they can seek jobs in the private sector. And then we have another college called DGT, College of Medicine, where you have the government is sponsoring students to go to that college. But they are failing to be registered. Can't have meeting the requirements. So one would wonder, why is the government sponsoring these kids to spend 4 years, 3 years, or whatever period that they spend in these schools? And then another government department says, we don't meet the requirements. So,
yes, I think the question has been asked. Let's hear the PS.
Okay.
It's a very valid and concerning issue. I've heard about it as well.
Thank you so much, Honorable Mwalus. We are aware of the issues that internship. The ministry has recently actually hired, and we are in the process of hiring 99 pharmacists. And so these would be all those that have been on our books. And our hope is that this month, 6 have already been cleared. And so our hope is that before the end of this month, the other 93 would be already in the service.
That does not address the issue. Internship. I agree you are only talking about 99. But how many graduates are graduated UB every year? So, have a graduate, but one internship, gain experience or license so that they don't necessarily have to be absorbed by the government. They can seek employment elsewhere. So, and they are willing to work for free.
Yes.
All they want is for wherever, and then they get that experience. What is stopping you? Are there any policies that are hindering you from absorbing these students? And if there are policies, can we help you change them?
Yeah, no.
Can I? Has this issue reached your office? It's a very important issue.
Yeah.
Has it reached your office anyhow, or is that an issue that your other officers are dealing with?
I am aware that there are pharmacists who need that internship. I know that a number of them were hired on that 1 year. And the 1 year is because the internship is 1 year. It's not because that was just for the nurses. So we have also made agreements now with the...
Are you saying the internship is 1 year?
The required internship, the required period of internship is 1 year.
That is required by the Professional Health Council?
Yes.
Okay.
It's 1 year. So, but often we do not have positions, as you've rightfully pointed out. We have agreed now with the internship office, the government internship. Ideally, we do not want to hire them using the government internship because they are working. They are providing their professional service when they are doing that internship year. It's just that they are providing it under supervision. But because we have not been able to find the position to absorb them, the internship office has said they can come to our rescue for those who would be able or would be willing to come through that internship. It's like 1.4, 1.9. That is not the ideal. That is not what we would prefer. But we are now going to be open to that. We know that Zambia went that route, and currently they are embroiled in a big fight with the young health professionals who said now the government is taking advantage of them. Because many of them, like many of us, come from families that cannot support them. So to send them to Totome when they have no other way of looking after themselves, it's not something we really want to do willingly. But we're hoping that with the internship office, it's still not optimal, but that we may be able to help some.
The response is not coming clear. I don't know, maybe if you're happy with it?
I'm not happy with it, but at least she knows. And she knows that I know that she knows. find out how many students have graduated from UB in the past maybe 3-4 years, and how many of those have been asking your ministry to assist them to get the mandatory 1 year experience. But we can leave that and talk to the DDT School of Medicine. I was at a Kota meeting in Savina, and Musadio Kata Pampir, Kilim Parliament against Kopin, Adin Tikelar, Pampir Zaman kids, who graduate Tile, Ubana Bereka Konyanga, Anale experience, but Habamo register Bare, Habar recognized DDT. College of Medicine or whatever the name is, but it's a school that is funded fully. These kids are fully funded by the government, and
whenever DDT.
The school is but they're from the former regime.
No, Honorable Bell. Arata Jaja, the institution got selling. Aram really, what the Ronarva Baba graduate level DDT. And Nebone, Honale Baba absorbing what the system in Saronized pharmacy technicians.
This 1 year DGT, there are some things that I may not necessarily openly say in public because there's an ongoing work between DDT, BQA, Ministry of Higher Education, Botswana Health Professions Council, and to some degree the Ministry of Health. And so there are some of those issues that I may not
These issues have been going on for a long time. I remember Honorable Hobutu also asked the question about DDT and an answer was given. Where are we?
Okay, what I can say is that to be sure that whoever you are bringing into the health system will actually be safe, there are certain minimums that they have to pass, just like anything. And so, in terms of DDT, I know that there is a registration exam, and those with pharmacy, a number of those with pharmacy have actually passed that and been registered. But the bulk of the other areas, especially medical laboratory, I think medical laboratory maybe just one, I understand, because, yeah, I think one. But what is most important to BHPC, Botswana Health Professions Council, is this person safe? And so they would use the standard that would ensure that would say, yes, this person is safe to be let out into the public to independently, whether to give medicines or to interpret blood results or to look at or to test blood results. So this is really the issue. Now, there are lots of issues that really are Ministry of Higher Education and BQA that needs to be dealt with. That as an employer, really, I should be assured the person is safe. We're trying as a ministry also to see how we can work with them to actually ensure that these people can come to a point where they can be considered safe. And there's nothing wrong with the individuals because they apply to a facility, an institution, and they were funded by government. So this is nothing about, and many of them are really very smart young people with over 40 points. So these are smart kids.
If one may, a conclusion one can make from your statement, PS, as far as qualifications in our health sector are concerned, has meted the requirement. That is the conclusion one can make from you. But from that conclusion
one can draw, has meted the requirements.
Ghana Ministry of Health doesn't accredit schools. Ministry of Health hires people who come from schools, but BQA is the one that accredits. So if BQA is accredited, I cannot stand here and then say it doesn't meet. But accreditation at BQA is supposed to also have the Health Professions Council having signed off, looking at the curriculum. Now it looks like somewhere along the way that did not happen.
Okay, go ahead.
It did not happen because they don't meet the requirements. PS. Issue one, Madia Hormenta Dirisha Musquelens, saying Hore, Banabating, ga bana mosola mo lehatsheng. Secondly, bana ke ba senyeditswe nako ebile ba tswella ba senyetswa nako. Le dira jang lona le ministry ha go ntse jana? A ga le dire dingwe tsa dilo tse pedi tse. One, recommend for the closure ya sekwele se ka gore se tswa mo teng ga se letello gore se ka practice mo lehatsheng le. Two, bana ba ba tswa mo sekolong se ba senyeditswe nako ba a ga se nako ya gore le ba re ithule so that they can be productive in our country.
Yeah.
That's
I was saying that there are some things that are happening. We as the ministry actually wrote to the Ministry of Higher Education to just about this. They are not the only health-related graduates. To say, because these graduates are currently are not able to function, what can be done? And so those are things that we are hoping that the Ministry of Higher Education is actually working along. We do go to those meetings also to have our inputs, but I think that's as far as I can say. But we are just as concerned because, as I say, we do not have we have shortages of some of those areas.
Landscape ya pharmacy technician ba BOTSWANA gompieno ba ba hirilweng e ntse jang ga se gore gongwe ano e dominate-iwa ke the foreigners ba bone gongwe ba accreditilweng ko ntle. Ke ra from what Honorable Moalusi was saying gore ba ga ba kgone go bona entry into the job market, and in the job market ba ba hirilweng mo di ga se gore ke ba ba tswang ko ntle ano.
I'm not sure which one, but I know one of the Institute of Health Sciences has been producing pharmacy technicians as well. And the University of Botswana also produces pharmacists.
Kora ba kgone go bona entry into the job market because ha ba kgone go bona di internship. Yanong ko madirelo go bereka ba he ga se gore ya no tla di foreigner ba le bantsi ko as a result of this.
I'm sorry, I missed the question.
You missed the question?
I had missed it the first time.
Yeah.
I will need to actually find the actual numbers, but they are, because for many years, IHS has been producing interns, not interns, but pharmacy technicians, and those have been hired for many years. So there's a significant proportion of the pharmacy technicians in the health system are actually, majority of them came out of the Institute of Health Sciences.
Okay. Honorable Moalusi.
I think tota kanya DDT you tota because kids are into drugs, but also good quelling into depression. Ka imagine one other food date abaya aro dira cause health. And because the government will organize the kwele gore ba go presenta ba go meet bana ko makhonele, so the kid will go there and meet the school, and they'll give them they'll sell their product, and the student will sign up, and then they do 4 years of school, and then they can get employed. So it's very, very frustrating for me as well as a parent. Okay, put my obedi. It's a short question. There was a court order in 2018. Any dental therapists, but skill. The court order, I think, was a very just a one pager, and it has not been implemented 12 years later. What's the plan? Court order. Do you want them to go back to court at a cost to the government and to themselves?
Dental therapists, yes.
Yes. Honorable Moalusi, I am actually not aware of this issue at all. So this is one that I would need to find out. I don't think it's too difficult to find out, but I am not aware of it.
Yes, how long have you been with the...
So you seem not to be aware of very pertinent matters within your ministry. One wonders over Morello Stavasa. Are you aware of people who have been acting for more than 10 years by actor, and at some point somebody comes from somewhere about the substantive position ahead of these people?
So let's not lose the issue that was raised by the honorable member who is on the floor. Yes, you can find out? Is that something you can find out during the course of today?
It's something I can find out.
Is that something you can find out?
Yes, Honorable Lucas, I can find
During
out.
the course of today?
Yeah.
Yeah, so we can go to another. Yeah, that's fine. What I was saying, can I go?
Okay. So that was supposed to be my second question. Me so go to my second question.
No, that was a question. They're going to bring the information, and I will allow you a follow-up.
Okay, thank you.
Yeah.
This one has to do with the data system that you have. How many data systems, different systems do you have in your ministry, including the EMR that you currently sourced from B3? And then and those systems that you have, how many of them are proprietary and what are the associated risks? And Yabo Hello along that line is, what is your concrete plan to harmonize all these different systems that we have? Because it's very strange that you go to this hospital that use a different system, you go to another one that use a different system. So what is your plan to harmonize all these systems so that you have a centralized health management system? Anybody can go local government, they go clinicing, can go central government, go hospitaling, can access a patient's information and data.
Yeah.
Yes.
We have quite a number of systems. We have the exact number I will find out just now. But what I can say is that the ministry has been working on a digital health exchange system, and that would allow communication of all the systems that we currently have, and also eventually we would want it to also be able to be linked to BOMANG and other government systems, so that we can actually track an individual through this. We can immediately identify them, and also with the private health system as well, so that we are able, when we give our summaries of whether it's mortality, or we can also account for those that happen in the private health sector. So that system, the health exchange, digital health exchange, is already actually ready to function. Now, in terms of the multiple systems, the plan of the ministry is actually to grow the EMR using the EMR that has already been developed for clinics, and the intention is to grow it and develop it even for the hospitals, which currently use IPMS, which is a proprietary system. And the IPMS currently have a 2-year contract, and our hope is that by the time the 2-year contract ends, the EMR would have been developed for the hospitals, so that we actually have that one system, at least for patient management. And then I will find the information. I know there was PIMS, and then there are other systems at the districts, but I will just get the full detail of them. But the plan is that eventually we actually have a harmonized system, and we would like to eventually get rid also of proprietary systems, because they are mainly because they are very expensive.
Okay, I think my last supplementary on that. I've been to a lot of clinics where they say Harina IPMS. Local government. What are you doing now to encourage or to give a budget to local government, or by encourage, because ultimately you are the custodian of the healthcare system of Botswana. But at least every clinic should have IPMS. Or referral to the next clinic, can I get to the next clinic? They don't even have a PC. What is the plan? Clinic is ote, computer internet or IPMS in the meantime, let's say EMR.
The idea, one of the big strategies that actually would come with NHI is digitalization. and ensuring that we are connected, all systems are connected. The pace of that depends on the resources, the availability of funding. That's really one of the big limiting factor. And obviously also of whether the people are, how easily and how quickly can people take up that, depending on their competencies and their comfort around the computers. I'm therefore not able to say to you, the hope was that this year would cover all the clinics, especially those that already have access to power. And so I'm not sure with the funding that we have, whether it's going to be possible. But we will work with our Ministry of Local Government. Ghana, when the clinics went to local government, we basically shared the budget or whatever we had been given, and we shared it proportionally between the Ministry of Health and Ministry of Local Government. So then with the plan, then the hope is that next financial year, then the Ministry of Local Government would also be able to budget for those facilities, with the hope that the economy would allow that to happen. But in terms of setting up the standards, the Ministry of Health continues to actually set up the standards and ensure that the EMR is the same and can be able to be completely connected throughout the system.
Honorable, you are beginning with something. Please be brief.
Yeah, I'll be brief. Rautla accounting officer something as you were Mehela chairman. Kore rona le bone le babereki botlhe ba government are accepting gore tota di haditsa mess in the Ministry of Health, and something must be done. Ministry of Health is one of the ministries still already bona a chunk of budget ya government. Me anong nna ke bona gore ka re do ka bontsi di bolwa ke corruption le go neglecta tiro gore gompieno yana maybe heta ka spitela ka the 6 mobile laboratories tse di rekilweng ka di million go 36 million, 6 million each. They are rotting at CMC. Finally, CMS, sorry. Yeah. CMS, thank you, Chairman. And finally, Ghana, donor agencies, the likes of Global Fund, the Global Fund, the ending is on Botswana carry. Carefully, let's do more with little. More than the ministry, ministry, the mobile laboratories. Thank you, Chairman.
But nevertheless, I think it's an issue you may want to respond to, PS.
This one's, Honorable Monarchy, I will find out about the laboratories, the mobile laboratories. What I can say is, up front, I have admitted that the ministry has not been efficient, and the ministry hasn't always used, despite the fact that we get one of the highest budgets, we still haven't, the results of our health system are not commensurate with that. And that is why our focus now is actually to optimize the way we do things. And so that I have outright.
The mobile laboratories, are you also going to find out? Yeah, it's fine. We had quite a number of things that you're going to report on after the break. It's fine. You can put them down. But Neki Sonia PS, you said you are not aware of them. Like, what you love a Hosa Omosha, Hosa Hodira Lewa. But what about go see about my information you're there. Have a jack answer over the Khan, 1 hour in me, you will have to find out. All of the Khan, Hosa Omosha, or when I can also enco what the Khan among the Patala.
The kgang tse le gore di teng tse di handlwang tse di tshwanetse gore di tswalo ke itse bontsi ja tsone, and we are working on a system to close them. ga ke mošwa mo go kalo, I'm almost 19 months in the ministry.
Yeah, that's a long time. Yeah.
So ke sone se ke reng dikgang tse dingwe ta bo e le hela gore ke a itse gore we have a number of court cases, and I know that we are close in many of them, but I may not know because we've had quite a lot of court cases in the past, 2013. And so I know we are close in many of them, but I may not remember the exact one. Yeah, dental therapists. I know many, but I didn't. I wasn't aware of that. The mobile, I wasn't aware where there was a problem with that, but I will find out.
Hey, go go ne ke tsongwe ke gona gore ka re tse dintsinyana ga di gore go mo go ene ke bona gore gore ha ngwa se kgang ya madi ko Ministry of Health go ke kgang ya di inefficiencies like you pointed out gore madi wa ne go ngwa a ka tswa a shota mme di inefficiencies di dira gore go lebega ke madi a shota thata. So
as already on the next PAC re boletse diputso re ata ka di re di romela maybe 2 days before. As the next PAC re dire diputso pele re mo romela 2 days before gore ata ka information.
No. Honorable Mabel.
What is this guy talking about?
Ska o manya ba bangwe Honorable Mabel. Me ke tsenya wena ya no. Hallelujah. Mabane na sa tsoga that's you.
By the way, thank you so much. Thank you, Chairman. PS, we meet again.
I know.
We meet very often. We are meeting on Thursday. Some of the things we will fight on Thursday. Today, you are a doctor, medical doctor. Thank you, Doc. Do you have enough doctors, Mobza?
We don't, sir.
We don't. If we don't have enough doctors, why then are we employing doctors temporarily? Why are you still employing doctors temporarily?
Yeah, this is one of the legacy things, but we actually are in the process of, in fact, we've already started employing most of them permanently. But this is a legacy thing that I think emanated from COVID. But we are employing them. We're starting to employ most of them permanently.
Yeah, you currently employing them on 6 months contract. And some of them you've been employing them on 6 months contract, 6 months, 6 months, 6 months for like over 3 years. Why? What does the law say? Are you able to just continue employing somebody on 6 months, 6 months, 6 months like that?
Initially, there were no positions, but now we have actually got some positions, and we are filling the positions. And so the positions, especially at D4, usually we try and reserve them, because when doctors graduate, they do a 1-year internship at C1. And then as soon as they finish the 1-year internship, they actually go to D4. And so it is important that when they transition, we already at that time have D4 positions. Ideally, you would think that, okay, yeah, so the D4, which are entry positions, sometimes we do have challenges. If, for instance, this year we hired more than 70 doctors as interns, and after 12 months, they need to all go to a D4 positions. So this is a positions for us that needs the flexibility to allow that when that happens, that we would actually have positions. So sometimes that the planning of it and ensuring that we have the position at the time, it can be a problem.
Yes, Honorable is making a very startling revelation here. Gore tota zo ringa ka dia shorta. Go shorta di position go lona.
The position di a shorta, Honorable Lucas.
Dinga ka tsone ga di shorti.
Dinga ka le tsone di a shorta ka go.
Yeah, go dia shorta elo mi di position ke tsone di sio. Ba bangwe bile ba hira temporary. I think it's a very interesting observation you have made, Honorable Bell.
Honorable, Ghana, the temporary vote it doesn't take from the established positions. So when our positions are full, but some of the hospitals and clinics realized they still had need, and they then hired doctors temporarily to meet their needs, but there were no positions that were available to actually be filled.
Can you continue with your...
I'm not sure if I'm satisfied with your answer, Doc, but then.
Chair, I don't think I hit the highlight.
Honorable, you want to make...
But one follow-up, gentlemen. Follow up.
Yeah. You want to make a follow-up on Okay.
No, Nalena, this startling revelation that Dinga Gadia shot, mid-hero on short-time basis. How many doctors do you have currently working at headquarters? And why is it that a doctor would, instead of being in a clinic, head some allied services co-ministry?
I nyadinga ka dia short kore se se buile ke re mabeo go supa o ka ra di short go shorta di position gore ko Ministry of Health ga ona di position tse di lekane, so you can employ doctors temporarily. Yeah, no, he's talking about baba ko headquarters.
How you actually want the total number of doctors that are in headquarters, or why we actually are hiring them in headquarters?
No. It has been revealed that on temporary basis. And I can attest to that as well. Indeed, hospitals, clinics are short of doctors. Yeah. Now, what I find interesting, I'm informed that one doctor is heading the Allied Services Co-Ministry. Then it got me thinking, headquarters, whereas we need them more grounding to do the work. Yeah.
I think I've not to a healthcare management to a degree level, master's degree level. But how is the forum like you go to Dr. Kayombo again, hospital superintendent. But we need him on the ground in the ward. Let's promote healthcare management, because by today's management isn't what the impressed. The impressed is aware and working and I impressed.
Chairman, it's like to say that to Lusa Tadadi.
Respond, Honorable.
Yagitata, you need Horescato Alabama Saramumi. Happy on the floor. And Nabagaba Fili. P.S. How come it seems like only doctors can lead? Co-ministering, the top 5-6 people, all doctors. Baba Limbo healthcare management, Balabo degree, Banaba Hono manager go ministry on Canalena, Kafuli Hiranangaten, Lilbo Doctor Lil Luciel. All top positions go ministering, Kiddy Doc Kidding a guy. Bonessa Gorar Bane Bazanafuga, Kanahaba, Habaru Terratat, Kanaja.
Yarmonelas Baga, Arabic, it's already Dukubukan.
Yeah, the doctor who's hired to lead the allied health. I know that I understand that he was hired because whatever the description of the job was, that he fitted, because that was a restructuring that even happened before I came, and then he was appointed to that. He had training in emergency medicine, and although he didn't finally write the exam, but he had training, and at the time, I understand it was because one of the big things that they were focused on is developing and establishing the emergency medical services, or working around the emergency medical services. So I understand that's how he ended up there. But as I said, that's what I found, and that's also my understanding. Now, in terms of healthcare management, I know that Tikanolo College has been training people.
How many do you have at headquarters?
Doctors.
Doing non-doctor duties, now administrative duties?
I have myself, and then the Secretary for Primary Healthcare, which is focused on, actually, this is the new restructure, focused on primary healthcare and developing the policies and the structuring of the primary healthcare system. And this person is a family physician. And then we have a director of health services. And then we have the acting secretary for specialized healthcare, because, as I said, our big strategies was to optimize the primary healthcare. So we needed
just go for the numbers.
Well, just the numbers,
Yeah.
because I just wanted to express. It was said why as well. So I was trying to explain the why.
Just give us the numbers.
Okay, the numbers. And then, so specialized healthcare. So I've talked to is myself, the Director of Health Services, the Secretary for Primary Healthcare, and the Acting Secretary for Specialized Healthcare. And then the other leaders are the DPS, the finance, and then the HR and admin. But then the other doctors that are there are doctors who are in programs, and they are public health physicians or public health specialists. So I think we have one who's in the TB program. One in the one in the TB program is not a public health specialist, but has done public health and has been working on TB for quite a number of years. One in the HIV program is a public health. One in the child health program is it? They are
Can
not
someone help you with the number? The number of doctors at headquarters. It should be straight cut, and
I thought so.
Now, the healthcare management is something that we actually are talking about now as to where in the system can these people who have graduated from healthcare management fit. So at the moment, as I said, we've been going through a restructuring since last year, and then the deployment structures have yet to be finalized, which is also going to look at is the way we structured, even the way the hospitals are led, is that the right way? And those are things that are still to come. It just is delayed because the clinics left, and then we had to redo the headquarters restructuring. But
Mateo, you're on the floor.
Nekinale ya bohelo mo doctors no impilo hore ke he chance. Thank you. Issue ke
so se dirileng ke gore ha ke go supa wena o supa mara o phologa.
Issue more establishment thing ya dingaka. Would it be correct if one was to say, currently, Sakai, you have, let's say you have 200 doctors on the ground due to 200 posts in the establishment. If you had 300 posts of doctors in the establishment, would we be having 300 doctors on the ground?
No. Because what we mean is, if we had all the positions we needed for doctors, would we be able to fill all of them?
Yeah.
No. Because the number of positions are determined by what is the expected or the ideal population doctor ratios. We're still quite low as a nation for population, even counting all the doctors in the country. So even counting those in private, our population doctor ratios are still very low as a country.
Doctor, we are not talking about population. Even if we were to talk doctor population ratio, the numbers of doctors that you currently have are still lower than the numbers needed for the current population ratio.
Yeah.
Is that correct?
Yeah.
If the numbers are low and establishment is super hore, the need that due to the ratio is super hore, we are low by 50 doctors. Can we get 50 doctors if the establishment, DPSL, says, yes, we will have 50 doctors Nathan, on the ground? Can we get them?
I mean, are they there in the country right now? Is that the question?
Not necessarily in the country. You have different ways of filling doctors' posts.
If we are allowed, yes. If we're given positions and we can recruit, yes, externally.
So issue ki establishment, the issue has dingaka. How do we help you with the establishment ko population ratio le doctors ya dingaka? How do we as PST help you? PSP is coming here. Maybe it's an opportunity.
Yeah. Well, to get that, you need the positions, and the positions is budget. So I think you would need both of those to be available to actually get the doctors. Because Botswana used to recruit doctors externally, and those opportunities are still there.
Okay. Follow up even in her answers. But because of time, Chairman, these temp doctors, some of them you interviewed them in February. And to the date, they haven't had anything. What's the delay? What is with the delay? These temporary doctors are not treated like other doctors, permanent and pensionable. For instance, permanent. This is just really bad, PS.
Yes.
I must admit that there were delays and these are just internal inefficiencies that we're trying to address, because doctors were interviewed in February and only a few have been hired so far, and we're still looking into hiring the rest of those who have not yet actually been hired, and some of it is, I don't know whether to call it the internal bureaucracies that we may say we have to have this, that, and that, and not be able to waive them even when our need for doctors may be higher than maybe that need. But those are things that you actually, if these are practices and processes that have been in place, you actually have to have a way of dealing with them to ensure that they no longer become impediments. But we know that we actually did have positions, and we had the doctors to fill the positions, and it's taken long to fill all of them, which is unfortunate.
Very unfortunate. Very unfortunate.
Did you answer
Oh.
Yeah,
I'm not sure the government pedium is a new thing, but the way to support someone who travels has always been there for government. And one of the issues that we're going to be answering for when we're looking at the records is our ability to actually recover. So I know that people who currently working as temporaries have not been given pediums, and maybe I'm going to ask Ma. Yeah. So can I just pack this one a little bit? I don't want to give. I've sworn under oath, so I really want to be sure my information is correct.
Doctor, you can't have a sorry pack and didn't see that. You don't only pack alone things same with you. You are one of the private hospitals, you call it crowd. Just pack it because there's a related question. Honorable Mabel?
Take med X-ray. Ask your team to get you information, because that's going to be my last question. Machine you will do take med X-ray.
Take med X-ray.
Yeah, get your team to get information on that while we go into the next question.
Go ahead, Honorable Mabel.
Oh, Doc, are you paid scarce skill?
Are you asking me as a person? Personally?
Emma, PS, Doctor, are you paid scarce skill?
I am paid scarce skill.
You are paid scarce skill?
Yes, same.
Okay. Then, if you are paid scarce skill, yet you are not a practicing doctor in the hospitals, why are you leaving out nurse? Other doctors, Baba, go ministering, are they paid scarce skill as well? Nurse, Baba, Berkanko, ministry headquarters, why are they not paid scarce skill? Meanwhile, nurse, Baba, scarce skill. Do you see this being fair?
Yes.
I'm going to beg. I know I've asked for a lot of things to actually clarify. I know the answer, but I just want to be sure I'm being accurate. So I will. Can I pick the doctors?
Chairman, this cannot continue. We cannot continue like this.
Well, we
we will not continue like this. This is quite unacceptable to us. This is a straightforward question with a straightforward answer. You are being paid scarce skill. Who qualify are not being paid scarce skill. What is going on?
May I humbly say, I am employed, and my conditions of service are not determined by me. So can I just, with that one, say I am employed? And the conditions of service now, we are currently actually discussing the conditions of service of all the healthcare workers. And there's a team that has looked at all the issues that affect healthcare professionals. And that is currently hard at work. And so I am going to, particularly around conditions of service, because this is an ongoing negotiations that I'm going to ask that I am allowed not to go into the detail of it, because my team is already also working on that. And they have developed a position paper around these very issues.
That you can answer, because we are talking about the status quo.
Okay. Can you just give me 1 minute, just 1 second?
Just 1 second, consult, just short conference. Let her consult first. I've got the total. Okay, but she's still going to give us the answers to the packed questions, the packed questions. Can I want to brief you on tomorrow? How so when I listen to what's an home at think you saw real tablets I like in Wapambir. Okay.
So I am informed that the nurses who are at headquarters are not paid scarce skills. They are paid overtime and what is called a post-basic allowance. And this is for people who've done a post-basic qualification. But the doctors at headquarters are paid scarce skill.
Okay. Go ahead.
So the nurses, when they're not paid scarce skill?
Overtime.
Yeah, PS is also paid overtime, commuted overtime. Along with body PS and other people, they're paid commuted overtime. But why was I doing this scarce skill?
So,
well, and you mentioned the position paper that you have crafted, which will look into conditions of service. I include the
position paper for negotiations. It includes all the conditions of service of everyone in the health system. I mean, eventually, if you're going to have a health system that works, you're going to have healthcare workers who are motivated and who feel that the system is also fair. And so the whole idea is actually to look at all the issues to ensure that there's a fair system. This status quo has been, and I found it this way. And so with these negotiations, because conditions of service are actually determined at a certain platform. And so this was in our preparation for this platform that's going to do negotiations.
Okay.
Honorable Mabeo, please.
I'm happy because from what I take from you, you are realizing what this is unfair and you will work hard to correct it. Is that what I'm hearing from you, PS?
What you're hearing from me is we're going to look at everything that makes the
Be specific. I'm very specific. I spoke about NESESQUA. You're speaking in general terms. The general terms you can speak later. I'm asking you a question and I want an answer. Specific. I'm talking about what NESE, Babakwa. You can talk about the general one, which I appreciate, but specifically talk about Yabon NESE.
Specifically talking about Yabon NESE, I know that there is an intention to make everybody the same who is doing similar things and same things. So the position paper is looking at whether what should be, how should they be remunerated better to actually ensure that what they are doing is being recognized.
Please.
Let's progress it.
Yes, I'm progressing it. Please. I don't bagages and Baba PS. I got to bagages and Linusi. I got bagages and Baba PS. And Ibile happy PS. Ke 12. Thank you. TechMed, X-ray. Hey. Which company was awarded to maintenance wa machine when the TechMed X-ray?
I still haven't received the feedback, Honorable Mabeo.
Yeah, it's packed. Honorable Mabeo, the last one.
Sometimes the information.
Yeah, she's going to give us the information after the break. I will give you a chance to.
You'll give me a chance
to follow it up. Yes.
Okay. So I pay for now because in a little follow up with the you know this issue. I'm machine or no X-ray.
Yes. Go ahead. And
what should I do, Chairman?
Ask the last question. For now, you'll be given a chance to follow up on those that are packed.
Okay. This machine or no X-ray. Do you know the amount, the contract amount? Also get the contract amount. By the way, I have all the information right here with me.
Yes.
Are you aware that this machine, Baneba Servisa, Baneba Koutilemo tendering yabone 42,000. Me, haba invoice about snaho servisa. Invoice wakizora neba baukeza gaziru kana neba decide awirang. But charge say 420,000, 400,000, 420,000. Me mo kouti yabone nearly 42,000 FL, less than 50,000. Yet they were paid close to 500,000.
Yeah. So find out.
Are you also aware?
Yeah.
Go Bubonom, Chairman, go constituency agago. Bubonom Primary Hospital. On a machine who trokotokau. Kana regulate something close to 1 million or just a little over 1 million. Main maintenance wa no one. Oko Bubonom, Chairman, can you believe? Cyclic maintenance, 900,000. 90% of the price of the machine. How is that possible? Cyclic maintenance.
What are the information here, Honorable
and then Hape, the contractor, is said to have removed some parts with the machine indeed. Because the machine is already break. So they need to maintain us. How do you break? The parts of system with them. Diko kai. But the generator in one occasion. Where are these things? Are the more mogolo nagana diko Johan?
It was a Chairman.
Yeah, I was going to say.
Be brief because
yes,
Mabel,
yes, I'll be very brief.
that was Honorable Mabel's last question, I guess.
Okay, thank you. The honorable member has really highlighted matlhoko a tlang ka monopoly. Ne issue, and many of these didn't follow up. Kgang ya go supa gore dingaka di ka kwa headquarters, for it to be taken this long, it's a worrisome development. But on issues of welfare, what are the healthcare assistance? Baba itshekang ka kgang tsa delayed progression. I've been informed that ha ba tswa kgotlatshekelo e tla dumalana le bone gore go na le delayed progression le progressa bone ba ba tswang ko court go be go tsamaya yet another batch le one e na le favorable ruling le bo le diragatsa se se buiwang. Question becomes gore kante ka gore la Attorney General o supile gore mo makgetong a dikgang tse di tsamaelanang ke gore go ra gore ke le sa diragatse gore le cover botlhe ba ba tsamaelanang le tshwetso e tserweng ke kgotlatshekelo gore le bone ba progress. Go na le re ba boela ko kgotlatshekelo ba go itsheka go senyega madi go be go tele ba duele ha ile gore ga lena madi wa ile sa ba engage la nna le a dialogue ya gore le khone go move forward. First, are you aware gore go na le dikgang tse di ntseng jalo, and what are you doing about it, even with the advice that we are rendering?
Okay. Thank you, Honorable Pologolo. I'm aware of the issue at the healthcare assistance and many other issues that have been ruled by the courts. Currently, the Ministry of Health needs in excess of 800 million to honor all the court's rulings that have been made in the last few years. And so our hope had been that by the end of this financial year, we would have at least close 92%. But
by the end of this financial
we had hoped, but now because of the financial provisions, we actually we had hoped that we would be given above ceiling budget to close a lot of our the court rulings that we have. But because of the financial situations, all the requests that we put for above ceiling provisions this financial had not been honored, and therefore we are aware that there are lots of people we owe, but we actually are not in any position right now to pay them. But the intention is to pay them.
No, potso e mo goreng ba ba di ruling ke a tlhaloganya likela go ba duela akere it is per ruling ya lekgotla. Potso ke gore go na le ba ba tsamaelanang le bone banka bone their peers ba ene gore the healthcare system me ga ba ise ba ye court gore are you also considering paying them or progressing them kapo le bone o batla gore ba ye court pele ga o ka considera go ba duela?
The intention and the idea and the hope is that we'll pay everyone. But as I'm saying, even those that right now we have a ruling before us, we actually we've not been able to honor them because of the provisions financially that we have.
P.S. Are you in a position to make an undertaking? Because as we speak now, they are grouping to go to court. What they need is for you to engage with them and make an undertaking that with funds coming, you will be in a position together with those with court orders.
Chairman, I may PS what lead staff meetings
Does she ever go around to check health facilities around, to speak to people, to be on the ground? When was the last time she did that?
Do you want to make an undertaking now, or you want to?
You know, I don't want to make an undertaking I can't honor and do that under oath. So I would need to be sure that to work with the team to find out what undertaking we've actually made already, whether it's already includes them. So I would beg not to be forced.
You pack it as well.
I beg to
for after the break.
For after the break.
Staff.
I do.
Okay.
I haven't for a little while, but I know on Friday we're going to be in Nyangabwe. But when I started, I did quite a bit of that. And then when the ministers came, we kind of accompanied them with for them to go around as well. But we have gone to quite a few facilities, but not to all of them.
Have you been to Hamalete?
I have not been to Hamalete.
Why not? Only fa. Only fa go se gope. Wakuchika khonela uri na ubuya fa Hamalete o check about BLH. Please, they are really in a bad condition. Ke a go kopa me. Ke uchika ka khona we go gama le lift le langa go pega.
Ke a utlwa short corner.
Please.
Honorable
Short right.
The last comment, and then we are going for a break.
Nane kere, kana tota accounting officer. I don't think we expect you to be know it all. Something about consult. I don't think we expect you to the letter. May you have heard, I think, from us, especially from Honorable Mabeo, very, very disturbing revelations. So, Sari Ampojanja. Megana wana mo doing a whistleblower. Kaka kwana at 3 places at the same time. Alona koholona. Do you allow such whistleblowers? By Moilore, Okano Okana Dore, Hodiakalanko Mau, Hodiakalanko Francistown. And do you encourage such? Because Gilakanamo Cancelara, and at that time, Gile sub-council chairman, the CS that I may not mention by name, Ona Abakanya Cancelar Onaka whistleblowers.
Okay. We do get whistleblowers, and very often, if they look like this is we do send our anti-corruption just to go and find out what the issues are, or if they are just administrative, we also try and find out. So we do follow quite a number of cases that we get whistleblowers. And okay, I was going to say I just have some information from the.
Yeah, you know, hello, Jim. You know,
so you got some information from. Sorry.
For some of the things that I was packing.
Oh, okay. So you also have whistleblowers here, right?
No.
We just gave you information.
Before the rate of may this could the rate of success. Aka abu very, very good information. They have whistleblowers, they have anti-corruption officers. How effective are they? Do they? Can Honorable Mabeo bicycle? Look at having a back and so 900,000.
What's the bicycle?
How to in? I gotta do X-ray. Okay. My apologies. Yeah, my apologies. My apologies. Mela, we do 90% of the cost. I think the whistleblowers should blow the whistle. The anti-corruption officers. Thank you. Thank you. Thank you.
Re buile di khantse dintsi thata the PS tse di batang gore mona go ikhutsana ke tsora to bona go ya gona te tota mona go ikhutsane e ra ha re boa tse o ka kgonang
Yeah.
o di arabe.
Thank you.
And then we are also going to give honorable members a chance to follow them up, high level what or the follow up. So we are in for a very, very long day today. So please, dirajalo tsote tseo di buitsweng, consult with your team, le ba ba tshwarang ka bohego, re tle re nne le dikarabo tsa dikgang tseo. Then ha re tswa ko re tla re tsenya honorable ke kgonegile. And then I get summarize, and then we are going to progress to the financials. But for now, please make a good job of gathering the information.
Thank you.
We'll give a slightly extended time for tea, which is 30 minutes, to be 30 minutes. Normally we give 20, but we'll give it 30 minutes. Thank you very much.
Thank you.
we can get started. Before PS, RNL information in Salisco Mara. I would call upon Honorable Khonerile Horle I engage le PS.
Thank you, Chair. PS Redumedisans, le team. I have 2 or 3, 4 issues to raise.
2, 3, 4.
Issue antaki the difference in terms of quality of health services between urban and rural areas and the distribution of resources within the ministry between urban and rural areas. Hona le pharologanyo e ntsi. Motho o ka botsa gore what are you doing to close, what interventions are you putting in place to close the gaps? Let's take, for example, staffing. How ya ko sepatela se tshwana le Tshola Thebe. Unit. How when e menwa ke bonnesa ba le 15 per unit. But if you come to Hongwe Sekgoma, unit in Nesua ke bonnesa ba le 25. What are you doing to close these gaps?
Thank you, Honorable Kekgonegile. It is true that there is disparity. And one of the things that we have been trying to do is to try and redistribute. We do face significant challenges in attraction and retention of healthcare workers, in particularly to rural areas. So I'll give an example. Because one of the things also, we don't want people who go to rural areas to stay there much longer than is desirable. So if I was to transfer, say, a doctor from Shakawe to Silibi Pikwe, for instance, and at the same time transfer another doctor from Palape or even Silibi Pikwe to go to Shakawe, what would normally happen is the doctor who's coming from Shaka will immediately move and go to their new station, whereas the doctor in Palape sometimes take a while, and so we're trying to manage, but because you give an intention to transfer and people make presentations, and sometimes takes a very long time to actually deal with the presentation. So it's really currently very difficult to transfer. So I think we need to start looking, but obviously that's a government-wide issue that we need to, how do we make rural areas attractive to attract and also to retain people? So that is an issue that we haven't yet completely have a solution. But one of the reasons that we started talking to the University of Botswana about decentralizing training, we thought if we can, as an example, decide that we're going to train family physicians in Khansi, for instance, as an example, and therefore the people know that if I stay in Khansi, I'm likely to go into the training program because the program is here. Then you are more likely that even if because the training is 4 years, even if after 4 years the person decides to go, but in the time they were training, they were providing high quality service. So that's something that we had hoped that we would implement by August, but we need to reevaluate given the financial issues and also the fact that some of the staff have now moved to local government. So, but that's one area that even research has demonstrated that if you train people in rural areas, one, you improve the care in rural areas because training demands a certain standard. And also, it's much more likely that people would actually stay. Not everyone, but some people would actually stay. So those are things that we actually had at work on.
Okay, moving beyond that, because one wonders if you'll be able to have training facilities all over the disadvantaged districts. For example, in Chobe, Kasane, Maung, Gumare, Shakawe, Khansi, Tsabo, I'm not sure you'll be able to have training facilities all over. What other modalities of retention are you thinking of in areas where you're not going to have training facilities?
Yeah. I must also say, though, that to train health professionals doesn't just need a training facility per se. What it needs is a good quality health service provision, because these are apprenticeship. You learn as you do. So, but then in terms of, the other things, short of better conditions of service, is very difficult. And conditions of service, unfortunately, they are not all resident within the Ministry of Health. They are government-wide that you have to negotiate as well. And I know that with there's work going on to look at whether the conditions of health professionals can be looked at differently from the rest of the public service. But that's decisions that well above me. We can put inputs, but eventually I think those are decisions that are going to, because those are policy decisions, and those are not decisions that I can make.
In terms of services also, the big four areas, the customers, clients, patients travel long distances to come for specialized care. But of recent, we are experiencing situations whereby these patients are not transported, more especially the low-income patients. So we are having high mortality because people are not transported to high care service areas. What is happening? And you disadvantaging the rural areas?
Well, this would probably be a resource issue, because it's not necessarily that the policy has changed in terms of facilitating people. And because the policy hasn't changed, and occasionally there are not enough. I know for a fact that there are not enough ambulances, there are not enough cars, and so those are things that we need to address. And so if they are not addressed, as you say, of course it disadvantages those who cannot help themselves. So I'm hoping, this is me just hoping, that with a move to local government, maybe they would organize themselves better, because it will be at local levels to facilitate movement, during referrals. But generally, we do need to improve our ability to transport, whatever transport, because even commodities sometimes takes time to transport.
No, but you are talking about primary hospitals or referral hospitals. For example, primary hospital transporting to Marina, Hosana Sepe. Can we afford that? What measures are you, mitigating measures are you putting in place for that?
Yeah. Thank you, Honorable Kekhonegile. We do transport. And so, as I said, where there has not been transport is a resource issue. But we do have some budget that this year we are hoping we can get quite a number of ambulances. But they are never enough, because we have 17 primary hospitals. But if we can only afford to buy 12 this year, this is the reality of what we're dealing with right now. But our hope is that if we buy this year, next year we buy more, it's more than what we have currently.
On the issue distribution facilities, recently we have seen hospital mo moshopa ha lo rasa hela mongwe le mongwe mo Botswana o na le tshwanelo ya ditamelo, but ditamelo tsa rona ha re di distributor, we must distribute them in such a way that accessibility to tsone e fair to mongwe le mongwe. Would you say how tshwantsheng ya sepatela sa Kasane Gumare le sa Moshopa, given hore Kasane the next hospital ke 600, the next hospital ke 500, Gumare the same thing, whereas Moshopa the next hospital ke 30 kilometers, 15 kilometers, 40 kilometers, wa gare ha dipatela le specialized care ntsi would you say it was fair for gore sepatala se be sa agilwe pele ga dipatala tse dingwe tsele go sena mo go tsone? Why le dira jalo?
I'm going to answer for the Ministry of Health. I don't know what informed the decision to build the Moshopa Hospital first. I think outright I will say that. I will also say that the Moshopa Hospital, compared to Gumare, for instance, the people in Moshopa, they had access that was much better than the people in Gumare. That one I admit. And I once more want to say I am not sure exactly how the decision was made and what informed it, but I think, needless to say, that the people in everyone who goes to Gumare can see that we really need a much better facility than we currently have in Moshopa, in Gumare. And I know that in the plan that is being challenged now because of resources, there was a plan to build a hospital in Gumare and also in Kasane. I know that even Kasane, even land had already been found because the space where the current hospital is too small. But I don't know with the resources whether it's going to be possible for them to go ahead.
So P.S. Chairman, just one.
Yes.
You are saying that it was not fair to build a hospital in Moshopa as opposed to those other areas. In your view, it was not fair.
Those are difficult questions. What I'm saying is the people in Moshopa had better access than the other people. So if we because I don't know completely what informed the prioritization, the way it was made. Given the information I have today, I would maybe have prioritized it differently.
Thank you. Moving on the second question. Relocation of primary health care. What disruptions are you experiencing? You have a challenge here, staff shortages, and all the sorts. And what interventions are you putting in place to ensure the service continues to flow?
Yeah. I think I would say that fortunately with the districts, the primary clinics or the clinics, is that the leadership has always been at local level in terms of this district health management teams. And so the teams that were managing care at the local level have now moved so that their supervision in terms of service is what has moved to local government. And also the challenges is that not only was there movement, but there was also some district health management teams were divided into multiple local authorities. For instance, the Greater Gaborone has given birth to the Mogodisane Tamaga, I hope that's what it's called, and the Hamaliti, and Klokweng, and then Gaborone. So obviously managing, because you're taking the resources that were in providing service to all these areas, but based at one point. Now you're dividing them into four. I'm giving this one as an example, but there are others across the country. And so those are the ones that actually, you needed to bring new leaders who were not necessarily leading districts before. So, it's managing that and ensuring that that process is also smooth. And then the other thing is we already have challenges with adequacies of resources, whether resources are cars or they are people. Now you're dividing them into multiple. So that is also another problem, because we do not suddenly have another source of money that we could add to ensure that. We had to divide the resource that we already had to ensure that all this happens. So those things are being managed, and to make sure that this happens, the teams worked together in terms of looking at what is available, where are the cars, what what types, and where can they go, and the people as well. Where are the people? And so we had to work, our teams, the unions, and the Ministry of Local Government actually formed teams that went around the country to talk to staff and also to talk to the leadership, whether it's councils or the Khosi, so that they could also support the move and make it as smooth as is possible.
Piers, now tell me about the primary health specialist, Oko Ministry. Now that the primary health is local government, do you still need the person or the unit, or are they also being transferred to local government?
Yes, I think I need to explain something. Ministry of Health can never be rid of the responsibility for the health of the people, whether they are at a local level or at whatever level. Just like primary education, even if local authorities may run primary schools, the curriculum, the standards, all those things are still the responsibility of basic education. So it's the same. The policies, the standards, because you need to have a national standard. You need to have a national, and that is the responsibility of a Ministry of Health. It's not just the Ministry of Specialized Care, it's a Ministry of Health, and health in all its totality. So what remains at Ministry of Health is policy, it's standards, it's regulation, and it's stewardship in a way. And then also, when the decision was made to move primary, it said primary services. So these are the services that were already being given, but not the responsibility for the health of the people in its totality. So those who are concerned with policy need to stay where policy is made.
If I may ask, what kind of engagement took place between the ministry and the workers, the staff, on this relocation? Did they choose, or were they just deployed?
Okay, so as I say, the workers' representatives were part of the teams that were working with the workers. But what I must say is, when government decided that this service moves to this place, so people who are providing this service, at least with this, the understanding, the people who were therefore providing the service would have to go, because otherwise, supposing nobody wanted to work under local authorities, then we may have to deal with what do you do with, but because government is moving a service, and therefore the people who are providing a service, our understanding is they would continue providing the service under a different ministry, because that's what happened in most of the, because it wasn't just the Ministry of Health where there has been these movements. There were other ministries, and that had been the understanding. And we are working with DPSM as well on these issues.
If that is the case, that there was engagement and unions were concerned, then why are you having heads of district writing to PSP requesting for audience in terms of non-engagement on this particular move?
It's a little bit difficult for me to say that completely. I know for a fact that we engaged. I know that because of the resources we engaged, we may not have had multiple meetings, but virtually we did have multiple meetings. And the head, who is the Secretary for Primary Healthcare, had multiple meetings. I mean, obviously some people were not happy with the move. And there were other things that happened prior to that also I know made people quite unhappy. For instance, the position of the district health management coordinator was always at E1, but then government during the what is the term I'm looking for? When the ministries were rationalized, that's the term I'm looking for. When the ministries were rationalized, a decision was made, not by the Ministry of Health, but by government, that position is an E2. So I know that this is actually the big unhappiness of these colleagues, and we've, you know, at our level we had tried to see whether that position could be left at that, but then the explanation was that because now the district, we are moving from 18 to 31 districts, therefore the spread of work of these people was no longer going to be so extensive. So they could, you know, the position could work at E2. So, and I must say, this was a government decision. And I know that is the biggest unhappiness of these colleagues.
What would that mean? Would that mean a salary cut for those who have been at E1?
It does not mean a salary cut. It means they have the personal, they will keep their personal rights. But it does feel like a promotion, a demotion.
Yeah, whoever comes in then will go to E2.
Yeah.
Okay, go ahead, sir.
Actually, this is PSP, I think. So all the state 1 districts, the DHMT are headed by doctors.
No, sir.
How many are headed by doctors? How many are headed by which profession?
That is another one that I'll need to get the exact numbers. But I know that currently also because a number of them were acting, then the Minister of Local Government would have an opportunity to actually appoint. But those that are substantive, I'll need to find out how many are actually headed by doctors. I think Dr. Ramsal
Thank
can
you.
find
The
out.
last question.
Yes, please.
On staff welfare issues, labor relations. Yeah, the ministry seems not to be doing well on labor relations. If one is to look at the current doctors' union issue and the current nurses' union issues, you are in and out of court with these particular unions, which are the major unions within the ministry mandate. What seems to be the problem? What are the conflict areas? Why are you not sorting these issues out of litigation?
The big issues are issues of conditions of service, Honorable Kekonegi. Conditions of service are not set by the Ministry of Health. And the Ministry of Health is a contributor, but eventually the conditions of service are done led by DPSI with our contribution. So the issues that our colleagues or the two unions are not happy with, there are issues that some of them had been negotiated and there seem to have been a difference in the understanding of what the agreements meant, and so that is what has led to this level of unhappiness. But my hope is that the current engagement hopefully will bring us some lasting solutions, because these things also distract our attention on the primary reason why we are there.
P.S. Are you saying makgotla a babereki le ministry kana le mohiri ba dumalane yaanong ha ba tlhaloganye gore ba dumalane?
No, I'm not saying. I'm saying some of the reasons, and because some of these things are still subjects of some maybe legal I may not be fully at liberty to discuss them in this public forum, but I'm saying that some of them, there seem to be a misunderstanding of what was agreed, yes, one of them. But others are generally conditions of service.
Would it be correct to say Ministry of Health within the government enclave has the highest litigation in labor issues in the country?
Probably, but I'm not sure. I'm sure Attorney General can confirm that.
Earlier on, you mentioned 800 million to be paid. Part of it will be legal costs.
Most of this is what we owe employees.
Okay. Who have been to court before, or overtime and other things as well.
These are people, okay, these are people who've been to court before, or those that did not go to court, but their colleagues went to court and there was a court ruling. So including at the HCAs that initially I said I couldn't answer.
Yeah.
I actually found out that even they are included in all these calculations because the understanding was if court has ruled, then everybody else who's affected would get to benefit. But the only issue now is availability of funds.
So, so you are partly answering the question that he put forth about the undertaking.
Yes.
That those who did not go to court but had similar issues will be paid.
Yeah.
So an undertaking now can be made by yourself.
They can be
that
made.
They will be paid.
Yes.
Thank you very much. I guess that one is settled. Go ahead, sir, with your follow-up.
Yeah.
The last question.
Health education assistance. This they have been stagnant for a long time. Some of them have been in B2 for 20 years or more, but it's a cadre that has workers with certificates, diplomas, some degree holders. Do they have an organizational structure?
Yeah. I think because because these are many, and some of them I don't have the answer off the top of my. I need to have our HR people to just help me, remind me about them, and so I will get an answer from the back.
Can they do that for the healthcare assistance as well? Because
that's what I'm asking.
Because they also seem to have issues. Those are health education assistants, and then healthcare assistants. They seem to be having issues around their progression, even issues of viability. It looks like the ministry is not even sure whether they need them or not. In the era of primary health care, those are the most important cadres anyway.
Yes, this is the one that I will get both of them clarified in case I confuse them. No.
Okay.
Yeah, because we're talking about cases before courts and all. For the under review peers, the Office of the Ombudsman is superior higher the case in 42. It's a ministry. And one of the things that the Ombudsman highlighted then was that they do make recommendations as the Office of the Ombudsman, and most ministries will disregard and not implement the recommendations. So question here is, of the 42 cases, Office of Ombudsman, for the year 2021-2022, we implemented the recommendation, it's a guy and also it's a guy.
That one also, I'll get the exact figures. I do know that we have closed quite a number of our ombudsman cases, but I don't have the exact figure, but I can get that.
Okay, so you'll consult as we go. Honorable Leroy, I know you're not in when we were engaging, and the likelihood is that you may even repeat some of the questions that have been asked. But do you have a burning issue that you want to?
I will not engage in that because I don't know what we discussed so far.
Yes.
But there is only one concern that was.
just start from beginning.
There is only one concern that was raised by one of the employees. In fact, it's not one. There are many of them. They are drivers. And they indicate to be doing duties that are beyond their mandate. But to someone less, and in terms of remuneration, nothing comes their way. So what are you saying? The concern was raised from Lobatsi, from Lepulule, and other hospitals. But their designation is drivers. But they are doing duties beyond what they are mandated to do.
I am not, what I'm aware of as a complaint from drivers is a group called the Driver Leading Hands. I know that, but I'm not sure about drivers, whether they are as a complaint from drivers in general. That I am not aware.
Those are the ones.
Because I think their complaint was that they are supposed to be transport officers but almost none of the facilities actually have transport officers, and so they felt that they were doing some of those jobs, and the ministry actually is currently rationalizing positions, and we're hoping that in this financial year we would be able to, at least to create 9 of those transport officers, because part of lack of those officers is what also has led to many of the damage to government vehicle issues not being attended to. So it would actually answer multiple things, but we are aware of their complaints.
Okay, thank you very much, Honorable Paulo. Just wanted to an issue that we just talked about.
Yes, because this one affects people whenever they have an interest. Court. You have since communicated to this panel. The next advice for me would be, can you communicate Lebone, reach out to them and make that very clear? Or else, like I said, because to make sure might not be of any help.
Yeah, I think just a piece of advice that maybe it is important that you communicate with them so that at least they know their fate. Right, so well like Yamadi, but at least buttons by when they are entitled issue can the resources.
Yeah, it's well taken.
I know you have been out doing some very important work around the welfare of members of parliament. But now you're back here, maybe you have an issue.
No, thank you, Chair. You know, excuse me, allow me to just talk to the Yes. Maintenance of facilities. What criteria are you using to select the facilities that you maintain per financial year? What criteria are you using?
Honorable Matausana, before you came, I did indicate that our facilities are in very bad shape. And for a number of reasons, but 2 of them, the most important reasons, are that we didn't always have preventive maintenance plans, which we have since developed. And then the second one is that often the maintenance budgets are very, very low. And they are particularly low because most of the facilities have not been maintained for a very, very, very long time. So that is why maintenance now is almost like you are redoing the buildings. So we've developed a plan. The budget is very low. And so we still then do tend to do reactive maintenance when things stop. But we really should have all our facilities well maintained. But for instance, recently we had to rush to Lesola Tebe because their theaters were not working, the chillers or boilers, and so almost the whole budget for this year for maintenance was used to fix that. So it's multiple things. We would love to be able to work with our stakeholders and agree, this is how we're going to be doing things, and be able to communicate. At the moment, we are still a little bit challenged to be able to do that.
But you now have a plan. You earlier mentioned you have a plan, but now the plan lacks the necessary resources.
Yes.
Yeah.
Piers, I was going to ask you to extend the same gesture to Tamaga Primary Hospital. Because I don't know what's wrong with your ministry. They have been there. I took all the ministers, Baba Hitiling, the three of them.
Honorable Mtausen,
say,
be reminded that this is a national committee. And,
yes.
Be reminded, and you may bring in Tamaga as an example, but if you are seen like now, you are dealing with local issues, it's not that desirable. But make your point.
I'm making my point as this is a reference. This is a reference. Ya go supa tsone di weakness ke ha ka se ka ise ke se itseng se ke buang gore di facilities di ntse ya mme ke tlhaloganya gore ke bua yana kwa go ntse jana ka gore she rightfully said all the facilities. Ke le ka go mmotsa gore a ele wa itse yone gore go iragala eng go yone. Okay.
Ke tsa gore nkutule.
Ke go utule se me
tsa gore nkutule.
E go tlhoka gore ke hite ka yone ka gore tota the situation there sometimes re tla tloga re tshwara ha o sa itshwareng teng e be go ya no ministry le ono bo la tlhagelwa ke madi a mantsi thata ka gore go ngwe you have to pay le bana ba batho ba ba tleng go bala ko PS ke ne ke mo tlestilong ga upeditse ke re ke le ka go kaetsa this is the picture gore gone mme can you call a primary hospital a facility like Yekotama always refer, can we call it a primary hospital? A facility like that one, Yekotama, can we call it a primary hospital?
Is a primary hospital. It's compromised, but it's a primary hospital.
Me ne ke ra go mo ka botsahela go rototsa ke Tamaga mo teng o ka botsahela ka criteria e dirisiwang e go characterize the facility as primary hospital.
Right.
Then give an example that helps, because you then have a premise from which you are emanating.
Okay.
So I don't know Tamaga, it doesn't look good. But anyway, go ahead. Ona go ditse potso re a yone mme ke primary hospital Tamaga.
Erra ke buile gore ke primary hospital e na le challenge mme ke primary hospital.
Okay. Maram 1000.
Okay. Gone me gore a primary hospital e bidio go te ke a primary hospital e tshwanetse be e le seemo se sentseng jang se ka ke gore gongwe e be na le not facilities the services tse di provider e ya be e leng e na le malao a le gore na le the accommodation tse di kae maphata a le gore a ba tlhokagala like how ya ko marina you find go na le bo surgical go na le bo maternity, go na le bo those maphata. For a primary hospital, gore go te ke yone primary hospital tota. E tshwantse gore e be na le maphata a ntseng jang a e leng gore ke yone a dirang a primary hospital.
What qualifies a facility to be called a primary hospital? Or
Yes.
it's just a name?
Nyarra, ga se dina hela. The primary hospitals le tsone di na le di-level. The level based mainly on the capacity, especially the bed capacity. But the kind of primary hospital is an extension of primary care services. In fact, when the decision was made to move primary services to local government, we were of the view at the time that primary hospitals should also move with the clinics. But eventually the wisdom and the decision was that it will only be the clinics. That being said,
Yes, no bua ka gore di na di level. And then wo tswa mo go yone. A yone ya tama ke level ma, level 1, 2, 3 o gona le 5.
re o lo tang kgakolla o ko morago le gore ke level ma.
A so ro mo gakolole motho e tsuka gore tsa gore wena you have matumelo istamaga level ero le dira gore yanong re dumela gore ga le show ebile o se primary hospital.
Yeah.
ga le itse gore ke eng tamaga ga lo itse
They will find the level.
You will find out.
The number of beds. Determined by the number of beds.
That should be.
Chairman, like I get cheaply in here.
I get why I don't go. I say what uncle. I don't go. You super hell.
Yeah, me uncle. Uncle, we are more than any hell of me. Kore, naka ngongorega. We have the accounting officer here. Of course, all questions dia go en. Melona senior officers. Certain questions. Ra go go rela gore atamaga e categorize kore e mo leveleng efe. I bidwa primary what. Abile sa itse batho ba modimo no.
But you see what I'm discerning from the team we have today is that they are not very intimate with facts about what they do. I think that is what I'm gathering. I mean, from even from the peers throughout the team, I don't see them very intimate with the facts about what they are doing, and I think that is not that is very worrying to me. I thought some of this information was so basic, they must know it. If the peers may not know it for some reason, but members of the team should know it. So you guys may be detached, but I suspect they're detached.
Che, as gore ba aba introduce re itse gore ke boma. Kana gongwe o tserela batho mo starateng la reng
No, we can't use that language. That was almost strategy.
I withdraw.
Okay, sir. Ba bereka mo Ministry of Health. Na ile ne ke tsa gore over topile ka tsela e ba ka mo facilitate ba mo thusa di kgang. But now, like Uncle Shima is saying, lona le ha ile gore PS ha go le lona le ikele thoko ao. Tamaga hela, potso hela e motho yo ne. Ka re le tare bo le isa ra motausa. Ka ke le ke moragere ke monsa motama o ganeletse mo go yone ya no le lona ha le re thuso itse.
Gone gore di-level di kae le gone
level di kae
di categorize jang.
Yes.
Ke eng ha le re ye ke level 1 ye ke level 2 ye ke level 3.
And then level 2 is 50 to 100. So there are less than 50 members of public confidence.
Okay. Inka yaraba.
Inka yaraba mtisi. Go ahead.
Tamaga ke level 1. And level 1, as I said, is the number of beds. Kera ko primary hospital. So level 1 ke malao a ko tsa 50. So Tamaga is one of them. And then level 2 ke 50 to 100. Dipedi di levels of primary hospitals.
Dipedi.
Yeah.
Okay, Honorable Mtausani, You been answered?
Error.
But go balwa malao go ngwa go balwa departments.
O na botsa ka departments. So ke swantse ne ke se tlhalosa gore kana primary hospitals are an extension of primary services. Ideally, the resources, these are the places where we should be able to find what people we call generalists, maybe like people like family physicians who can, at a specialized level, look after babies, look after pregnant women, look after the elderly, and do some basic surgical skills, surgical operations or surgical processes. So that is primary hospital. So it would be staffed by people who we call primary, even if it's specialists, primary care specialists. Those are primary hospitals. So it's not, there's no plan for these are the places where you find surgeons and physicians, except for where we may make a special consideration, for instance, places like Kasani or Shakawo, based on the distance. Knowing that those we might actually just make the distance, not because this is what is expected of primary hospitals, but because of the special circumstances of those hospitals.
Okay, Aram Dazari?
Yes. Likile la hira di pharmacist. Ka kontraka nyana ya ngwa ga ile nngwe hela. Are you aware that go na le bana ba leng gore ba ne ba hirile ba BOTSWANA temporarily? Me gompieno ana as we speak gala ba hira me le hirile le renewile tsa batswakwa mo di position mo di posting tsone tsa di pharmacist. Are you aware of that?
I'm aware that we've...
And you know, Piers, this question is coming again. He was not here when it was asked, but he's bringing it. That also shows you the importance of this matter.
Yeah. Yes, sir. I'm aware that there were pharmacists that were hired for 1 year, and some of, as I explained, the internship that allows them, especially the degree holders, the internship that allows them to be registered as pharmacists is 1 year. That's a mandatory internship. So the 1 year was so that they could actually do the internship and then be able to be hired anywhere, because then they are eligible to be hired. But at the present moment, we're just completing a process where we've hired 99 pharmacists, and the majority of those are BOTSWANA, if not all of them.
But Piers, what I'm saying, irile hali renewela ba batswakwa ba BOTSWANA bone bele sa ba renewel. Why did you prefer to renew for the foreigners when you have BOTSWANA pharmacists available? Why?
Thank me to the chairman.
Yes.
Se se diragetseng ke gore 2023 ne le ba hirile ka contract ya 1 year. Then abe tlaire 2023 la be le renewela the expatriates contract. The last time how ba extended the contract this ba tswa kwa ke ka May. Mabani jana kana ke no khiduni ke mabani yelana hale ba renewela ba di expatriates. Why le renewela ba tswa kwa di contract mme go na le bana ba bantsi jana mo strateng ba ba sa bereking? Why are you not hiring BOTSWANA kontle?
Okay. I am going to get the exact information, but what I can say ke gore I'm aware that there are some expatriates contracts that were renewed, and these were not entry-level contracts. There were people that were maybe coming at a senior level, because even when you bring new employees, you do need to have senior employees in the system. But in terms of entry level, that's what I'm talking about now, that we are hiring now. It is BOTSWANA.
Senior level, what level, PS?
Okay, the levels because I do know that I have chaired a board where there were renewal of contracts, and these are mostly senior pharmacists, but I will get the information.
How much information at PS?
I I have a lot of information, Honorable Mabeo, but I can't have all the information about all the recruitment.
Anya PS, is it E scale or D scale?
The pharmacists.
The pharmacists.
They were the ones that are coming from outside Botswana.
D scale.
D scale. Surely you can go sa promote baba thing and then why are you not doing that? Because I have a friend who is a pharmacist myself, personally. I sent an umbrella this information, by the way. And I believe she D4, I believe. And on experience since we C1. C1. Why was I Baba Godimo Baba Chokwa or Baba Sutelane, Hosen Baba Ngutlas? Why little renew the contract about Basai Berga Gomahawin?
Honorable Mabel.
You sound very xenophobic now.
But
seriously,
PS, this is a serious matter. This is, Honorable Dawsani, you made a very important point, and also Honorable Malusi, sorry. Malusi Abuakayoni, but we are not Akayoni. You're also bringing the dimension Yaho Hero, but about some contact. Janu negri PS, how are you better Helaka? I want to come.
May I think I understand where you are coming from, but I also want to assure you, Hori, whenever there's a vacancy, we look at qualifying BOTSWANA first. That one I say it under. You
assure us that whenever there was a vacancy, qualifying BOTSWANA will take precedence, and in future as well, that will happen.
This is because because the positions that open, especially senior positions, are usually very few, and yet
very few BOTSWANA.
No, very few positions that open, and then usually, as Honorable Mabel was saying, a lot of people. And yet there are many people, say at C1, and usually maybe 1 or 2 positions would open a D4. So to try and make it as fair and as competitive as possible, we advertise and everybody applies. And yeah, what I'm saying, I'm making.
D scale, but foreigner. You are C1 in as well as C1, we are good D4.
I think I'm trying to explain, Honorable.
Please,
Lucas.
I'll give you a chance.
Yes. When a position opens, a senior position, not entry level, it's advertised. And when they apply, we always take qualifying BOTSWANA. When we have dealt with all the qualifying BOTSWANA, it's only we would take foreigners.
Yes.
This is when a position opens. When there are a few cases, study pharmacists, where a senior pharmacist, especially in areas where many people don't want to go, that the department then may make a submission to say, Ghana, we will advertise this. People advertise, but generally, once you offer, many people do not want to go to these places. And therefore, we would have, I will need to get the exact information, but I know that would occasionally make that, particularly in areas where it's very difficult and BOTSWANA don't want to go.
BOTSWANA Baba C1. One of the chance let's call them here foreigner go D4. BOTSWANA Baba C1. Is that what you are saying?
I'm talking to renewing a contract.
Yes.
If the contract, I mean, we would advertise, because we said every position at D level, we're going to advertise them. So we will advertise. If a qualifying BOTSWANA applies, we would actually give that to the qualifying BOTSWANA.
Haribana foreigner alimo D4. Hope helamu. A pharmacist.
This decision we made last year. So I can't talk to contracts that have expired long before last year.
No, kibuaka foreigners ba go pieno ne ba renewela. Ke re go bua ka tse di ga o honor mabeo ka re ka kene o ka re o di tsintata. Ke re ona bua ka tse leng gore batho ba te ba renewetswe mo ngwaga o hitileng ile di foreigner e sentse bogologolo wena o ntse le mo stilong ba renewetswe a ha re ba bona re itse gore ke ba e leng gore ya no di foreigner tseo e di tsene mo placing ya motswana yo ganneng go ya ko mahelong a.
Honorable Lucas, can I please ask, because the numbers aren't huge, that I will ask to be given those so that, because we're not talking about hundreds of people, it's just a few positions.
Yeah, there are 14 of them, 4 of them that you renewed. Even this skill can I know PS. Are you saying you had advertised for those positions? Did you advertise? Can you show us where you advertised those positions?
Honorable Mabel, may I be allowed to get that information, please?
Okay, Honorable Chair.
But the information you, Honorable PS, PS is very worrying that go ka tswa gona le possibility ya gore batswana bangwe ba sa promote di position tse go le renewela di foreignera di contract. We would not want to sound very xenophobic, but it's only just unfair. But look, give us the information. Wait. No.
PS go na le kganye ya gore
Honorable Mabel
ba HR ba batla ma 3000 gore ba hire ke go ba gore o tsenye DCEC mo kganyeo go na le bangwe go HR ba batla gore ba nelo ma 3000 gore bana ba hirwe ba. Please take this and note this one. I gave solely any feedback from you, but please I go by report o tsenye DCEC or DIS so that ba HR ba be.
Can we listen to the chair? Honorable Mabel go na le passionate about an issue you want to make, but there are also rules of engagement here. Can you please, Honorable Mabel, respect the rules of engagement?
In Charlie, Chairman.
Thank you very much. Honorable Mtawazana is your last one, and then we'll be going to those issues that were packed.
Thank you, Chair. Me PS kanye kane ne ba tsenela mo go yone. Ke kopa gore o ye go ile ba le bathata gana ha ke dumalana le wena gore batswana ba gana go mahelong. One thing that a Motswana person would do ke gore bogolo o kampa tsa position ya tloga a itoka le kgakala ko a rapela gore a busedwe kwano mme a tsere that post. So it is very unfair ka ha le hirang bana ba ka teng. In the same context, me is a pharmacist. Ma baniana helayana, nela advertise the post the video nursing what. Me wa itoro na post the advertise at a level ya wo metro no what. Holela le cancet. Matata ke eng sa tswele diswa jaka ne le advertise it. It's senior positions the level I think body 2 D3 go e cancel ka gore gape a hale le D2 D3 ke ha ite go dua nursing what ke nursing superintendent and having go something like that.
Okay, before the advert say how he's in the nursing. Yeah, there is a gentleman there who tule uncle or batus.
The information I have is that the advert was not cancelled. D2 D3. The process of selection is nearly complete. And so they should be hired soon, if it's the same one, sir.
That one is for which category?
D4, D3 for nurses.
Oh, okay. Cancel on.
Yeah, in the work on a pharmacy, singing nurse, singing a bonus.
I'm surprised what the cancel or gona le bonnes mudastiro ang komanya ngitsa go bua maina me gona le bonnes ba bangwe ba ileng gore ga ba bidio ebile that issue was nearly going to court ka bonnes ba nne ba itse ka gore keng le sa re biletsa di-interview le rona mo dikgang tse, yet we qualify. And dikgang tse PS
mapele honorable Mtausane o ka re kgang ga e wele sentle a ne le process ya teng go hetse go gore go le mo di-interview right kwena o ntse o doropa dipampiri nko o sebetse
I know that there was an
a go thuse a confirm sentle kgang
The interviews were not cancelled. All the D4s, D2, D3, D1 have been interviewed. They went to court and lost. But challenger who shortlisted. It was D3, D4. They were 700.
okay
Okay. No, I actually know the case that Honorable Matausan is talking to. Matausan. I apologize.
That's okay.
Matausan. I'm sorry. So the positions were, the advert went out, and then after the shortlisting for interview, a huge number of applications were received.
After the shortlisting?
No. When the advert went out, there was a huge number of applications that went out. And then obviously then you administratively you need to shortlist. I don't remember how many people applied, but there were well over 600 applications that were received. And so the nursing department at the Ministry of Health then went through and did the administrative shortlisting. Okay, maybe I'm giving an example. I'm not saying those were the reasons. We said we need because if you need to do administrative, then you're looking for reasons to cut because you can only interview a few. So they was okay. We said a certified woman. You didn't bring certified woman, so we're not including you. Not even because all the people who applied, they meet the criteria. So you have to find administrative reason why you will not take. So eventually, those who did not, who were not selected, went to court, but then they lost, and then the interview process continued. That is why we're saying that the offers are going to be given soon.
Your answer, around 1,000.
Yes.
Okay.
On this issue, it's health, the HR issues, labor issues, industrial relations issues, it's health. Di na le thokotsiamo e ntsi. Ke eng go ntse jalo? Ba neng ba tswa primary health care go di counseling ka 2008. You are likely to find gore ke bone ba majority e khatilweng on that particular exercise. Ke eng go ntse jalo? And then go na le issue ya skills mismatch gape e ntsi mo ministry wa gago. You can find motho ana le BA humanities a dira procurement in your ministry. You would find motho ana le environmental science background ile a rana CHBC program. What is happening in your ministry, PS?
Ke tsa gore o ka garela ka yone ya HR industrial issues in your ministry ka re gona le ngwe go etona thata mme le ya ona mo 1000 ke tsa gore o lekile go ya araba but our selection ya teng ile ba ikete hangwe na in favor of those ones ba le go central government. I don't know whether you want to speak to that. Attempt to yaraba home, Madam Accounting Officer.
Yeah, skills mismatch. Why?
Argore lanta bone selection ye ne dira ka bone batho ba no ba bua ba le 600. We tell like it anu e biased if favor a certain section say ban ban central government exclude ba ne mbale ko the district.
But I wouldn't know why. Because I mean, at the time, I know, for instance, that this was going on. The acting director of nursing had been someone who came from, well, who I would hope would have been more sympathetic to people who had been with the councils, if there was a reason to. But because administrative selection it's really an admin, it's a tick box. So I don't know how that would come to play. So Tota, I can't talk to that because I'm hoping that people were honest in doing the tick box. Okay, so because that is really administrative. Yes. Now, in terms of skills mismatch, we are aware of skills mismatch, and that is part of what I said at the beginning. Or one of the things we are doing is to really try and look at our processes and look at where we're having challenges. For instance, we are aware that in procurement, there are people that are currently doing procurement, but they are not equipped with the right skills and the right competencies.
How did they get there, PS? How did they
These are legacy issues. These are people that you find in employment, and you have to find a way. Either you're going to have to skill them, because we are all, well, I'm not, but majority of people are permanent and pensionable. So we're going to have to find ways to actually ensure that eventually all the right people are in the places and are doing the work. And some of the legacy issues came from programs that were externally funded, because they brought people that then the agreement was that when the project ends, the ministry takes over, and then you will find that you're taking over staff that come with the project and are doing things that that maybe the ministry would not have itself hired those people. So there are many reasons, and most of these are legacy reasons that we are trying to correct.
So one could also conclude that a ministry has a legacy of not doing things right in terms of industrial relations. But anyway, let's Honorable Thousand.
e kana gore ga ke a botsa sepe ka gore tota di le dintsi mme ka ke itlhela le tsweletse tloga ke repeat
a re dumalane go ema gone go ke go kope jalo mothetso ke go kope gore o eme
chairman
o eme honorable anka bona nako nyana ko morago ke ta go sekunyetsa gore ke lebile nako ya rona ka kwana le yone. But there are a lot of other issues that piled before the break, so I want her to address them.
Because it's very important to raise this one.
After lunch. Honorable Malus. Ta go kubela nkangi man ne ke re gona di kgantse di saletseng ko morago tsenne PS o no a re sologetsa gore o ta nna o di sekaseka le ba gaeno ke a itse gore ko honorable uncle Shima ne go sena epe o na le tsone
na le the 6 labs, mobile labs. Okay.
6 labs, nearly 6 million each.
Okay.
CMS.
So what we've actually...
Okay, staff said, "Can about to buy feeder halila, but you like what was an amor no how it's me by the requirement the project AMC to be wrong the level di bolako, but I would like chairman of ask at and more Tamahato Tata.
Information if you look Mihala Raskarazana Tamahato. I think I agree with you. Mihala Honali Hangisi Neditaka Honorable Uncle.
So we've established that these were mobile X-rays in vehicles that were supposed to...
Mobile X-rays?
In vehicles.
Okay.
So, Jan, the X-ray themselves, so they said they didn't see more the facility. In fact, I have the names of the facilities, and now these trucks, actually, we are looking into some of them, converting them to office space, because they are just they don't have any equipment anymore. Those equipment now were sent to Princess Marina Gweta, Mahalape, Joseph Kavinda, Mahukunzi, and that way contained.
So when Titwe Malating.
Because the truck were just to provide the mobility at the time for the project. Yeah, they needed that.
How long have they been sitting there?
That's the information that I will get in part.
An advice from Mogolwane in this committee. A potso e tlampa issue etla le seleselele the issues that are around it. Kora ha go tla complaint or concern. Here are laboratories. It's 6 million each. Di bolla go CMS. Aka karabo iskanela gore nyamiri ntshitse se senang se le mo teng. I be go tui. How long have they been there?
I guess there should be an answer.
Right now, there's no answer.
I think there will be an answer. I mean, how will you look at it? I think there will be associated questions that will be answered. So, how long have they been sitting there, these mobile X-rays? Now they cannot be called mobile X-rays now because there are no X-rays inside. How long have they been sitting there?
The project apparently started in 2019.
2019?
Yeah.
And then when were the X-rays removed? Linsite lendi X-ray. Hapo ka ipotsa ne di wadara lo ha lo re ano ha ditaga go so go antshiwa the X-ray moti. Why this?
Na chairman, I beg ke khuluma ka lengwalo. Kantile mongwe nare can we know? I think this has been happening with other ministries.
Can
we know?
Sorry, Uncle, can you allow a short briefing there?
Okay.
These apparently had been bought for the survey bias that usually goes around the country. So it was at the end of the project that the X-rays were then taken to facilities.
Okay, so you're had your limbas?
2019.
Yeah, 2021. So they have been sitting there now for about 4 years, right? Lindsay the X-ray, the X-ray.
2023.
Okay, so around at least 2 years they have been there.
But these are equipments. Equipments can have economic lifespan.
Yeah,
but anyway, Chairman, let's do like we have been doing with other ministries. The accounting officer because what is happening now with the Ministry of Health, that I carry with due respect, I carry relevant people really. So now you compare for 2 minutes. Baba executive, Baba Tuna, junior. Sorry.
Honorable Malusi. Kahana ba ka teng kana no eno e beile segolo ke Paulo le ke go gana ya no kana Honorable Malusi na ba ka tsela ene ya dira gore sie mo go yone ka speed me ne le kopo hela gore PS ba batla go itse gore ona le bomang tota ne re rile tana re ba itse re ntse re tsweletse
ka go bohelong ka kwa ke na le Maisrael ke no o ka missing CMS at the moment.
EMS.
Central Medical Stores.
Central Medical Stores.
Janong
ipue mbatwetso.
But now our committee CMS are more leveling if
the acting director was Central Medical.
Thank you.
Okay. Assistant manager. ya ke re manager a go queue
Manager ke.
e ga sene e ne ke re o to thusa di account a re tswelle okay ba mati okay what can you come again well how do you mean like okay
Tota, ideally, Modula Stilone, we had wanted to also bring our DPS were HR and admin, but we were constrained by space, so they had to go back.
oraro o togetse ne o mo tsaba bangwe ba le palonyana but anyway ke tsa gore le ipuile lotlhe that settles it ramnageng let's go to honorable Pologolo o nana dikgang tsa di follow up le ko le ke tsa gore one of them has been dealt with yeah court cases and nana le tse
Can I just do them in the order it would be quicker?
gone tota ya teng ke a itse gore bone maparlamente batho ba ratang go tsenela dikgang yaanong ga ke na le ke itse gore ne eletsa gagwe ke ta mo ha chance go na le ba bangwe but anyway ha ile go di tsaya ka maina jalo is fine let's go
ne le boditse ka di cases tse di go ombudsman ke shame I think na botse
yes ke
no go na le tse di 42 tse di 22 tse di resolve tse dingwe we are actually working on resolving them.
Any follow-ups there?
It's been 3 years now to 4 years. When should we expect you to have fully resolved those matters? Because some of these issues have negative impact on staff morale.
Yeah.
Thank you very much. Another one?
Follow up.
Time, okay, time frame.
But we wanted to at least those that are not going to add significantly to our 800 million what the court cases. We wanted to close all this year 92% of all our cases, not just the 21, 22, but all those cases would be closed.
By the end of the year?
The end of financial year. That is what we had worked this financial year.
That's March. Thank you very much.
And then ne re kile ra botswa gore di DHMT di lidiwa ke dingaka jaanong the current honorable ke kgonegile the current DHMTs dingaka di 6 di dietitian di 2 bonnese ba bararo pharmacist mo hela lab scientist ba babedi se le gore di
nko boele di palo tse DHMT nore
district health management teams
e di lidiwa ke bo mang ko boele di palo
tse 16 di lidiwa ke dingaka tse 3 ke tse 2 ke di dietitian tse 3 ke bonnese e nngwe hela ke pharmacist tse 2 ke di lab scientists.
Thank you very much.
It doesn't add up to 31
because ke sonse ne kere these are the ones tse leng gore re ntse re na le tsone so ha di transferiwa therefore ha di dividewa ke tsone tse leng gore new heads needs to be appointed so ke ne ke bua
le ntse re na le 18
so the
okay
ke bone ba nentse ba heta di HMT.
I think that's answered. Let's go to
and then enwe which one is this one? Oh, okay jano ka gore go up to adding to 31 go ba currently acting ke 11 doctors, 1 pharmacist, 3 lab scientists, 1 health promotion specialist, and 14 nurses.
Okay.
dental.
At the moment, dental.
Meno ga ba. Are tswele pele ka tse dingwe ke wena o di tshwereng ka kong.
Enwe ne e boditswe ke bona gore ga ya hella thata ene e botsa gore di pharmacists tse di filweng through interview recently tse 2 ke ba di 1 tse 3 It's a 7 ke D3, it's a pedi ke D2, but the information is ke bone gore ga ra e kwala ke gore which of these ke ba tswa kwa kana ke ba tswana. I think I will just ask them to.
That becomes the most important information, though. That becomes the most important information. Are tsweleng ka tse dingwe o ta e baakanya eng?
Now e nngwe e ne e boditswe, I think re phologolo still ya heading the private labs. Kana ke re
Private laboratories?
So gore motho a letlelelwe go operate a private facility, whether it's a clinic or a pharmacy or a lab, they have to have a minimum of a bachelor's degree, and then they have to have a minimum of 5 years of work experience. Currently, there are 30 private labs. 17 of these are owned by BOTSWANA. 13 are owned by foreigners, and of the 13 private owned by foreigners, 6 of those are associated or attached to Diagnofirm.
Okay.
Do you have facilities, government facilities that are run by diploma holders?
At the moment, we do have primary hospitals and clinics, facilities that are run by diploma holders. I think the understanding is that because they are part of the whole system, they are not independently making their decisions, and so they have some oversight, somebody who has oversight on what they do, because they don't set all the standards. The standards are set elsewhere and they implement. So that is at least the current wisdom of the reasoning. Whereas when somebody runs a private lab, they actually are independent, and their decisions are not easily. Nobody has any other, unless something goes terribly wrong.
I think that is a very dangerous statement, PS, to say people can do as they wish, because they are regulated. The very licensor, BOTSWANA, is the regulator. So they are on their own and they can do as they so wish. So if they are able to run government facilities, they should be good enough to run their own private practices, as long as they follow the requirement that's in licensing. So I think you should park that one, go and discuss it further, and include these BOTSWANA, because for the longest, they were sidelined by that requirement, allowing other people from outside to come and run laboratories here to the exclusion of BOTSWANA by Lengore. They gained vast experience over time.
Where is the requirement contained, if I may ask?
There's a private practice licensing committee that is a subcommittee of the Botswana Health Professions Council.
So it is the one that is the source of this particular regulation. So like you say, maybe it's time to engage now, given what he's talking about, that these people have got vast experience on matters of private laboratories. Is that something that you think makes sense?
I think that's something that the Health Professions Council can definitely engage and see.
But you have to engage them. Should it be us or you engaging them and say, well, I had a conversation with members of parliament, what do you think about this?
In terms of letting them know, I can. But we really do want our oversight bodies not to have undue influence by government.
It's not undue influence, it's just to communicate a matter that you were alerted to, or
I will surely do that.
In fact, Mr. Chair, some of these Hadisi Molo are the very people who were setting them. They had motive. So you maybe need to go back and look into your policies and review some of these to accommodate, intentionally to accommodate Botswana, rather than stifle them from participating. Thank you.
I think the point is made. She got it.
Can I also say that these licenses are actually only available to Botswana?
For private laboratories?
and pharmacists and things. It's just most of those who are there. These are legacy. They've been there, but now new licenses are open to Botswana.
Only Botswana.
Yeah.
Okay. I think we should move with some speed now. Because,
okay. Yes.
Yeah.
Okay. Then there was an issue, a question around the. Okay. Let me just look at it. Sorry.
There was a question about the old Naledi, some plant somewhere.
There was a question about warehouses.
Yes.
So what we've established is that the ministry has a contract with an entity that owns 3 warehouses in Gaborone West. I think that's what he called in Old Naledi, Gaborone West. And these are 3 warehouses, and each paid 17,813 pula, 33 thabe a month. And I understand these contracts apparently have been there for many years, and they have been renewed.
Oh, what is many years?
At least 10 years. So the understanding also that I have is that 2 of those are now expired. 2 of the because it was one entity with 3 warehouses that were procured as a package, and then 2 of those contracts have expired, and currently the ministry is actually looking at. Decision was made not to renew that contract, and a new procurement is taking place. Now, in terms of the equipment that was in one of those was the 20 hematology analyzers that were apparently bought during COVID, and they were determined that they were below the standard that actually we currently use. So they were used during then, but they are no longer being used. They do not meet the standards for what we would require when we're doing a hematology test. So therefore they have been disposed of, I'm told, in 2022.
Okay, the contract is a legacy, say, it's a warehouse.
Apparently, these were 4-year contracts that have been renewed.
Okay.
But now the decision has been made not to renew the contract.
Okay, that's fine.
So, can we come clear on the equipment that is lying in there? Has it been disposed, or they are still in storage? And we are going to look for new storage for the same equipment.
I am told that this equipment has been disposed of in 2022.
So the warehouses lay idle. There's nothing stored in there.
So as I said, there were 3 warehouses, and apparently they came as a package. And one of the warehouses is still being used. It has equipment that's going to go to Moshopa Hospital, and that will expire this year. So the understanding is by then the equipment would have gone to Moshopa, and then the contract will not be renewed. One of the others expired in March, but has been extended because it has a PMTCT to allow for the procurement process to be completed, and so it has PMTCT products. So unfortunately, it does seem that the warehouse where that had that equipment that has been destroyed is still being paid by the Ministry of Health.
Okay.
The equipment
until the contract expires.
Yeah.
Or like in a year's time, or
no, the contract. This one is the one that expired. In December.
Yes, we need to move with some speed now. We under pressure of time.
The equipment in the warehouse, how do you dispose it? And
This one, I would actually need the technical people who would know how to dispose laboratory equipment. I will need to.
Okay, any other issue from our side that needs to be?
The other question that had come was around dental therapists.
Yes.
So I think the issue right now at hand is that the Ministry of Health's understanding was that the court order has been implemented accordingly. But the dental therapists believed that the court order had not been implemented. So
how does that happen? Somebody's not being truthful there.
Because apparently there was ambiguity in the way the order was written. It wasn't very clear. So I know that apparently it makes reference to those who have relevant and appropriate qualification, but it does not actually explicitly say what are those qualifications. So the ministry thought they had paid those who had the qualifications as they had understood them. So in 2021, apparently the dental therapists, it was the union actually, applied for a contempt of court, but it never proceeded. I'm not aware why it never proceeded. But the parties are continuing to engage because the ministry then went through all the folders of those who are still believing that they are owed. And I understand that they already were going to be meeting this Monday after they'd gone through all the files of those who are still aggrieved. So
Mwalu will keep an eye on it.
I wanted to comment on it. It was my question. The people who are complaining because there were two paragraphs in the judgment. So they are complaining about the second paragraph, which says the respondents to ensure that the assimilation process subsequent to the implementation of the directive number 36 of 1998 does not disadvantage dental therapists who have taken up membership with the applicant. Applicant ke bopeu. So what are the therapists disadvantage because of their membership of the union. So that is the bone of contention. Make court order and a will or make sure disadvantage.
I guess it's a matter that you will engage because you are saying you are engaging.
Yeah.
So, Honorable Malusi, I know him, you'll keep an eye on it. When we next meet, there should be some progress report.
No, I just wanted to confirm what you say. This thing has been ongoing since 2021, I guess. So the reason why the contempt did not proceed was that there was a difference in interpretation. One is saying that you're disadvantaging me, one is saying no. So that is why parties continue to engage, and the next meeting is on Monday, where parties will continue to engage on that issue.
Please engage, and there should be no discrimination on the basis of...
disadvantage. I think that was the reason why the judgment was explicit. Let's call it disadvantage.
And Muhire continues to say, no, I'm not disadvantaging. The other party says you are.
So let's engage. You say Monday. Yes, Monday. So please engage. PS is an important issue.
Yeah, and I wanted to correct something that I had misunderstood what the note that had been written about nurses at headquarters. About nurses at headquarters, because that's the question was asked by Thank you, Honorable Mabeo. Okay. So I did not communicate the correct thing. The nurses in general, not the ones at headquarters, enjoy or earn overtime and post-basic qualification or post-basic allowance. But apparently, those in the Ministry of Health do not earn either of those. So they actually lose both of those allowances. And I'm told in the past there was a court case around the issue that that then was lost. But I think the rest of what I said is correct, that, because these are really our conditions of service, and that is what we would be part of engagement.
What do you call the go health?
Ra?
What do you call the
But Mohoyone, I think the bone of contention ke hore dingaka metsone le ha di se mo practice indirect di le kwa administration ha go ta mo di allowance ntse di le hanging dingaka, they get them, but the other professions within the ministry ha ba se ko practice ba le mo administration, they lose what others in the practice get.
Yes,
that is the bone of contention.
No.
Or you need to sit down and iron out this thing.
I completely understand it. I know that initially nobody was getting any of those allowances. And I know many of them went to court. And almost most of these allowances came because of a court ruling. So, but obviously we don't want that to be the way we do business. So I think I've already, in answer to Remabeo, we will engage.
Okay, so Piers, you are promising today you are going to follow up on that issue. Because over time so you're going to follow up on the issues.
As I said earlier, because these are conditions of service. Ministries define these are the conditions, but eventually decisions of what allowances would be depend on the overall bigger negotiation. But those are understandable.
The X-ray.
Maybe bila kungwe just engwe ka bonambo he ho ke ya enable dwa ka the temporary doctors.
Yeah, Remabeo.
So currently there are 140 expatriates who are employed on a temporary basis at different levels. The 12 at D1, 7 at D2, 8 at D3, and 113 at D4. And we are trying to actually absorb them, and we are looking for positions from we're looking for positions from DPSM to absorb them. Now, in terms of Botswana, all those that were temporary at entry level at D4, all those have been hired into permanent and pensionable. Those that were Botswana. The few that are remaining, the 15 that are remaining, are those that are not at entry level, because the positions, but what I have received now is that they also have now been hired, and so they should also receive their appointments. This is the information about. So the ones that would really we are waiting for positions are those that are not Botswana, but these are just based on availability of positions.
How many are those based in Botswana?
140.
Okay.
Piers, I don't think your information is correct.
Okay.
Because the person who spoke to me is a Botswana doctor who did not go for that interview earlier February. Ke kafuku kutwa ngate war interview la February le bazanelo makolo batla hirwa. Okay,
then I agree.
so that information is incorrect. Remember, you are under oath. Tell your people to give you the right information. Because that one is completely not true.
Because X-ray.
empe ke follow mo go yone ya dingaka ise go ha go bonga ka hana batho ba le ba hirang bana ba di foreigner bana ganke le bogolo yang ba gore le ba ha contract tse dintšhwa ga le ke le batla go itse ka bone gore mme ba ntse ba dira jang ko ba dirang teng ka re ke lemoga gore o ka re yanong re setse re hira hela ka gore re tlhoka dingaka o be le gore motho a tsa a iswa at D1 level yone yo gongwe ebile go torana spatela e be le gore o tlhelela gore ke gore go tshwana le spatela se itsamaisa I understand bangwe le setse le ba renewetse bone ba mohuta o yaanong you need to know gore a mme bone bana competence ya bone kana ka because now I suspect bone ba di foreigner gape gantsi ikela ke dumela gore e tla se dingaka ko ba tswang teng ba tsena kwano kore le na le position e nngwe actually bitseng kore bo nne se ba ikelang le bone ba le mo leveleng ya gore o ka re ke bongakanyana isene kore ba sa studisa for bongaka go motho na a dirile nursing a ba ya for further studies o tshela le gore ke batho ba tsewang ba kgonang go stepa in ha go le botlhokwa ngaka a se jaanong bone batho ba ke dumela gore a be le ba mohuta o and ba hirwa go te ke dingaka ha o tsena go go tshela bona gore ke mathata ebile ka re go thama ga re tshabelwa ke go romelwa batswa kwa le bone ba managing spatela sa ro.
How do you ensure these people are qualified?
Kana re hira batho ba ile gore they have been registered by the Health Professions Council.
Okay.
So we our trust is that by the time they get given the license, they are the right people, and those who are in our system, we do get the assessment by those who supervise them, and so we expect that what they say is the performance of the people is their performance. So if this is not the case, then we'll need to look at the way we assess our people.
Chairman, it is so because we can recommend ka gore we can le chain ya bone hela bone ba tswa kwa go simologa ko ministry e tla be le gore
no honorable Thousand ha te ke professional health council a ke ba tswa kwa batho ke ba tswa
by Health Professions Council
ke ra bona gore nna ke tsa gore a ke rekise a body residing Botswana I topegetse ba tswa kwa thata
what I'm saying ke gore una awela ka gore ba supervisor ha ke tsora ora bona professional council
no this one is
ka ba ile gore ha ile gore ke ngaka for instance gona le ngaka o mo supervisor go ngale ko thamaga go ngale ko Scottish ba ile gore ke bona ba recommend gore nyame you can renew for this one so I don't take it to be correct because let them more ministry mon but ba hira batho bana wa bona gore ba hira hela gona le khanyele ba hira nyela ba bona gore ga ba diriti
honorable Thousand but this is a two-layered process but check wa ke professional health council go tsohong sa se buang gore ba supervisor mbone ke ya bo ile a re latela ora rutwani ka gore o bua gore go na le professional health council ke yone yanong gatekeeper e leng gore ka ba amogela gore nya ba ka practice go tsohong a re ba beile mo di supervisoreng tsa bone ke bone ba ka ba questionang but me a bo gona le a re ngwe ko godimo
Another is dead air. How we also tsuba about
I thought sorry chair. Niki sabat go
that obviously I think it's just a genuine mistake.
Interrupt ka gore niki tsa gore you are still on the floor. But what I'm saying ke gore professional counsel e ka ba here ba ntsha dipampiri ha ke re ba ntsha dipampiri hela ba dumela gore ke bone tse di gore dire motho ke ngaka o qualify ile go nna ngaka now ha ba sna go tsena go fielding bokgoni ba bone ga se bone go tlhelele mme kana ba supervisor ngongora ya me gore ba supervisor chance ya gore ba ba recommend for renewal e kwa godimo ka gore ha o re o lebelela the chain ya gore yo ke mangwe mo supervisor yo ke mangwe mo supervisor yo ke mangwe mo supervisor o itlhela ntse le bone ba tswa kwa bone bao so ga go motlhogo gore o ka re ga ke recommend semamma
is point taken akere it's a jalo ka gore akere o supa gore ka tswa gona le digepe in 10 minutes we are going for lunch.
Ke kopa gore ke bue ka ya gore re kolota boka ya di x-ray santse ke batla di dates tse dingwe. The supplier this one is just CMS, Central Medical Stores. Ka 2024-2025 re santse re kolota di supplier total in Botswana Pula ke 17,133,071 Pula. But they
Honorable Mtausani, please can we pay attention to the presentation that one was a deposit to the Arabic.
jaanong tsa foreign currency tsone ke 25-26 okay thank you sorry so and then 25-26 re setse re kolota in total 315,417 pula 869 pula 13 thebe
315
million 417
right 315 million kolota di supply
315 and then in total re kopanya la last year gora ke 332 million are re swantse go ra duele di supplier ba central medical stores.
Is it within your capacity to pay?
Well, yes and no. Some we've already exhausted this year's provision. Ka gore ne re duela a lot. We had a lot of people we hadn't paid in the last financial year, so a lot of funds went into that, and then some of these that we owe, we have made. We have already processed payments, but some of the payments is not honored because there is no cash.
Okay. Let's go to another one, please. The private facilities.
The private facilities.
You call it up, guys, on
229 million.
Malawan go siane thata go to bo go duelo ga ba duelo go tsa ba duetse gore ke a setseng a
re ba duetse as soon as the financial year started. We paid what we could pay.
And how much did you pay?
And but
we could get the figures again.
Yeah, we can still get the figures.
Thank you very much. Let I want like information you give it to our secretaries. What's okay?
TechMed.
Yeah, from Honorable Mabel.
TechMed. It's apparently the okay. The rating. Okay. So the machines were installed in 2009, and then they were upgraded from analog to digital in 2020. And the machines were serviced in 2022, and the generator, which apparently was the thing that was fault, was taken to South Africa for repair. And by a local agent. And in 2022, So now apparently this agent has changed, and is called by a different name, or whether the company has changed. Now that has delayed the return of this generator, and so the machine is actually currently not functioning as we speak.
Is only one machine there? Or?
This was the one that I was talking to the Bobono, because there was and yes, at the Bobono was maintained and upgraded at 947,442 in 21-22, and the cost included all these, putting a new CPU, interfacing, and then they've written a lot of technical things.
For obvious reasons, if I may ask, is it working?
That is what they're saying. It's not working because the generators has still not been returned from South Africa.
After paying 940,000, it's not working. You are telling me.
And how much was the machine purchased for?
So
and which company is that?
The company the local agent for that company is at Floritech.
Floritech.
And then
yes,
it's called Hypex.
Is that so?
Error.
Floritech, Mr. Chairman, a former minister's wife, and it was given direct appointment, right?
One thing, Chairman.
I'm not aware.
A small
former minister, wife. I can mention who.
Your name is 940,000. Your name.
You can still find the owner of that company even today, a late minister's wife.
Yeah,
one thing, Chairman.
Direct appointment, unacceptable. It's not just this one. About 10 different locations, about 10 different hospitals. They maintain them at an average of about 800,000.
Yes, there is a scandal in the Lumi.
A big scandal here.
Can you please look at that matter and give us a full report to our secretaries?
Yeah.
There's something, because even when I heard about it from Honorable about 900,000 maintenance, I thought maybe you got wrong information from some wrong people. But now it does look at least one case. Gives an indication. Oh, yes, give us the report, please, through our secretaries.
One question.
About the company. It has now changed names, you are telling us.
Yeah, true.
Okay.
So what I do have now is, actually, it is true that in 2018, there was a request to waiver to the appointment of Floritech Investments for maintenance of 18 TechMed Ltd radiology equipment in government health facilities for a period of 24 months at an estimated cost of 10.2 million Pula.
One question, one quick question.
Yeah. Direct appointment to this company of a former minister.
Question one.
Yeah, me kizari utile right. Rekupile gore ernelo reported saying because there's something fishy about all this thing. Go mo hela se se gakamatsang. Honorable Munare.
Nane kere. Kore accounting officer. Go ne ke tsana le chairman ha honorable antsa bua ka 900,000 cost of repair and all those. But I really being carefully. Kore ya ka ore le na le whistleblower, le na le anti-corruption officers. Why has it taken some of us or all of us to be getting this information quickly, within 2 weeks, within a week? Lona mera di wetsi diragetse bo 2 years ago, bo eng ago. Sorry, nya di diragetse some time back, make it real hell. But it's sorry to say this, they are happening under your noses. No one tips you, no one alerts you. Millennially whistleblowers, lenale anti-corruption officers, ba re ba tsamaya go di ignorance. I think checking.
Checking. Koraya. Agruaria.
Che, I think maybe gongwe ke gore kana re bua thata gona le go botsa ne ke tsela gore PSO mo tseleng ya go araba dipotso tsa ga honorable Mabeo sa gore o na bua gore hilwe tender ya 10 million but na sampo ke bona ta bua gore are in 14 centers na sampa ta bua gore machine a take bokae go le mo hela lo ka re na sampa araba gongwe re mo he chance ha ta helela ntse ke gone re ta go batang report
Ibile ke go pa o tlatsa mo go yone because gone go lebega gore le ha ba ne ba quotile ene 10 million yo it was way more because remember PS really about 18 centers. It's actually more than I thought. But each machine ba maintain at a cost of about 800,000, which means it's a lot more. It's a lot more money than the 10 million. I say this because more quotation for this X-ray tube, 42,000. Enable charging 420,000, close to $500,000. Look, people are saying more Google or check out Rejabukai. Like go America is about $6,000 which is about 75,000 today's. Maybe it's $500,000. Unacceptable.
Yeah, nerekupe or skara go tsena ga no hantsona le tlhaloso ngwe e o na le yone hita you reinetse.
Yeah, ke ra gore gone ke dumalana gore re ta disa a full report ka gore information e ke intsi ka go gape e kgologolo gore re ta tsone ke gore go bata information ya teng.
Ha o ilebile hela PS ga o bone ro ka re di something fish.
Ga ke ilebile ga ke bona gore madi a teng a mantsi gore gongwe be ne le direct appointment yalo so I would need to find out gore ne tota ne gore kwa eng ke ra gore it does make one want to find out more.
PS ga o etsa ka thohalo ke go pajalo
Erra
o etsa ka thohalo ka gore go lebega ka re dikgantse ne di buiwa ke toka ke mainane ke nnete lo ene wa di repeat gone wa in fact is true ne ke re o tare ha report e tetseng ka kganyone
le ke re gongwe re kope a re he report le mo go engwe gape go na le ya a chapwe ya circumcision gore gongwe le yone re ka kopa briefing mo go yone hela gore go lebega a chapwe na le kontraka nngwe le bo JP Piego something like that. Something like that. JH Piego Corporation. Gore le ene go lebega hiwa tiro ya ngwaga after 5 months wa o keletswa gape ka madi a chapo tiro e ga e hele substandard but still ntse go a tswelela extension ya contract ene le maloba hela yana mo kgweding yone ne ntse heta.
Thank you very much.
May I just ask, Achapo in Holomadia Tengasoko Ministry of Health, can Achapo is an independent entity?
Ke dona re batretela gore Ministry of Health is coordinating on behalf of the program ya circumcision. I coordinate from Ministry of Health.
I will need to find out about JHP. The reason why I'm saying we do coordinate with a lot of NGOs, and they have multiple funding streams, and so they may not even be getting money for what they are doing from the ministry. But we'll find out because you've pointed it out.
Thank you very much. Any other
health education assistance?
Did you get the information issue? Health education assistant. Okay.
Thousands of Kenya peers negrele. I also aware of one of the se bolong go act for about 10 years in the position.
Ga ke tsora gona le batho ba ba actileng 10 years me ha ile gore go teng we would need to. Okay, so when we I would need to find out more about it.
Okay.
And
But
then
which ke dumela gore kgang tse re di
HCA.
tshotile unless o na le dingwe tse di setseng.
HCA le mahea, ya no. Healthcare assistance scheme of service is from B2, B3 to C2. Just like all other cadres, or progression to higher scales, because usually the higher scales are usually fewer than the entry levels. So progression will really be determined at the number of positions and their availability. Mahea, however, on the other end, has both
Mahea ora health
educational
okay.
assistant.
Ska tsa ra itse motho.
Sorry.
Ha se bola re hia ya no nna ke ne ke setse ke tsene ke tsabetse.
Banale, both a technical cadre that goes up to D3 and then a professional cadre that goes up to D2. And how they progress really is just determined by availability of positions.
Healthcare assistant hantle ba hira boneng me.
Healthcare assistance.
Go gona le batho bangwe ba kile ba video go te family welfare educators. A ke tswa ke mahea go tsa ke mai.
Yeah.
Ke mahea ba.
That family welfare educators were a very special group because most of them had a very short training, but they're an important part of community healthcare workers. And right now, we actually, we really believe that we still need that cadre of people at a community level because they really deal with issues at community level before they become a big problem.
Bomma professor. Go bono. Ke bone gore yone card ya January le ntse la ba hira kana ha bua ka primary health care gore re card you becomes very very relevant. Le ntse la ba hira. Ra?
The unit evolved into a new unit, a video health education assistant. It's actually video family welfare educators.
Okay.
But now, as none about video health education assistant, babata hobtswella baba suppressor to the net and scale it's because of the legacy.
Okay.
We are supposed as a unit or a whole.
Okay.
So he was just explaining Hori. We still hire the healthcare assistants. However, because of the limits, last year we had frozen hiring in order to absorb those who used to be called hospital orderlies, and then they've gone to get extra training. And so we had prioritized that they should be redesignated because the hospital orderly cadre is no longer available in the system. So it's just to allow that all the others also be able to be redesignated. That's why a delay.
Let's go back to Mahia. You are saying professional level, they should be at D2, can I headship to D2, technicians to D3, certificate to C2. Kitsela hore a progression within all government structures, it's all government departments. How on the units, can the department but the issue is thank you within your 31 districts. Do you have any here? Almoh D2. Do you have any here? Almoh D4, for example, at a diploma level. If that is not the case, why is it not the case? Why are they not progressing? Jaka organizational structures, a professional bone, ba progress. Aki bone hela, baba talk and the post within the Ministry of Education to the extent that a person with a diploma, I have not 20 years, more be two.
Yes, that will be the last response, and we are breaking for lunch.
The nitty-gritty of this, I'm in my mind, but then I can't depend on my mind because I need it to be properly informed. The mahia at these levels, there are in terms of when did the professional cadre actually start to then be able to see how far, if all things equal, how far would they be? I would need to really look at it, please.
Thank you very much. We are breaking now for lunch. When we come back, we shall proceed with the financials after clearing one or two things that may be left behind. Thank you very much. You are invited for lunch. No, not for dinner, lunch. We will have supper.